All the best.
Let us have a fierceful debate.
Yes.
And healthy one, of course.
Namrata, you're muted, I think. You can count.
We are live.
We welcome all of you for our ARC webinar on Challenging Debate series. The essence of the webinar was to thrash out some very relevant controversies and get better informed in the process with the very best of speakers who are geared against each other today. We are delighted, as always, to have the very best of expert panel on stage. Our President, Dr. Mahipal Sachdev, our Honorary Secretary, Dr. Namrata Sharma, our IRSI Chairman ARC, Dr. Gaurav Luthra, our very dear past President, Dr. Debashish Bhattacharya, and Dr. Srinivas, our member ARC South, will be moderating along with me. Without ado, let's start with the first set of debaters. So get ready, debaters. Dr. Gopal Pillai, the Southern invincible hero from Kerala, is going great guns in the posterior segment, and Dr. Rajesh Sinha, our Honorary Treasurer AIOS, could beat the very best at any point of time. The topic of debate is most relevant and debatable. Scleral fixated IOLs should be in the domain of VR surgeon, as against anterior segment surgeons to be equally proficient. Here we go, starting with you, Dr. Gopal Pillai.
Thank you very much, ma'am. Can you see my screen?
Yes.
Yes, sir.
Yeah. So my time starts now?
Yes.
Yeah, scleral fixed IOLs should remain in the domain of vitreoretinal surgeons, what I'm speaking about. I have no financial interest. I believe that anyone can learn anything. And the typical example is Professor Dr. Rajesh Sinha, who was my senior, who was trained in cornea, but joined as an assistant professor in retina before he came back into the anterior segment to be what he is right now. But when you're looking at a procedure like a scleral fixated IOL to be given to all cataract surgeons, even China talks about medical ethics. Now, what does scleral fixation entail? It is about putting an intraocular lens just behind the plane of the iris and fixed at the scleral region. Now let us look at some of the statistics of retinal detachment. Out of 100 cases, 42 RDs occur after cataract surgery and trauma, which are the cases which SF IOL is being done. Dr. Rajesh's own statistics from RP Center says that 63% of pseudophakic retinal detachment occurs for PC RENs and sulcus IOLs, which are basically the cases in which SF IOL needs to be done. RD is 30 times higher in cases with lattice without PVD, which are the younger patients with trauma in which SF IOL is done. A population-based study, 11,500 retinal detachments trauma, 16 times risk of RD, 12 times risk higher with vitreous loss, 20 times. It is not 20%, it is 20 times. So you understand why is there a 20%, 20 times, 30 times increased risk is basically because you touch this particular area right behind the iris plane called the vitreous base. And the vitreous base is very tightly adherent to this area. And even if the rest of the PVD occurs, the vitreous base is the culprit, which if you manipulate, like when you put a blunt instrument like an intraocular lens into that place, partial PVD, total PVD, retinal tear, retinal detachment occurs. So in a basic surgical principles, there are few principles. First, do no harm. Infrastructure and instrumentation should be adequate. The surgeon should have adequate training, and the surgeon should be able to perform, evaluate, and manage pre, intra, and post-operative problems. So let's look at them one by one. First, do no harm. It's already a compromised cornea, and that's why you were not able to put an IOL in the first place. It's an aphakic. Any problem in the pars plana, pars plica, vitreous hemorrhage. Vitreous base, if you have any problem, abnormal VR traction, cystoid macular edema, epiretinal membrane, retinal detachment, endophthalmitis, a lot of problems. Is the surgeon adequately trained to handle all this? So retinal surgeon is trained in ophthalmology and cataract surgery, but cataract surgeon is not trained in managing problematic abnormal vitreous. Why is that the surgical retina training is not part of MSMD curriculum? Is because blinding complications occur after a single mistake. So when the cataract volume is high, we can train MSPGs, but SFIOLs as well as retinal surgery volume is very low and training opportunities are so low. So better managed by someone who knows how to handle anterior segment and abnormal vitreous. Now, can the surgeon evaluate pre-op problems like peripheral vitreoretinal traction, which is a transparent three-dimensional issue and an indirect ophthalmoscope, or vitreous base, partial PVD? All these, the retinal surgeon needs to look at it. What about intra-op problems? Any bleed will cause immediate vitreous hemorrhage. There is no PC. Peripheral retinal traction and tear, any vitreous base avulsion, any central vitreomacular traction, dropped IOL. The cataract surgeon cannot manage all this. What about postoperative issues? Vitreous hemorrhage to peripheral tear, to RD, to dropped IOL, to ERM, VMT, and endophthalmitis. Now let us look at Shankar Netralaya statistics from South India. Post-op retinal complications were seen in 1/5 of patients with SF-IOL, 20% of patients. And these retinal complications in the post-operative period, a cataract surgeon cannot manage. Policy making is basically dependent on a risk-benefit analysis. And the number of SF-IOLs required to be used in the country is not large enough so that all cataract surgeons need to be proficient in that procedure. Adequate people needs to be trained. It's not about finances. It's going to be faster. It's going to be slower. It's going to be more not so common. You require a vitrectomy machine. You require a good cutter. So the finances are not the problem. Why should a cataract surgeon do it? I feel it's the ego factor. And I think that many of the cataract surgeons who are in this panel, they would have forgotten the last time they got a PC rent and faced a vitreous. It's face saving. It's not safe. Whenever in doubt, you put your dad as the patient. Would you want a cataract surgeon there, or would you want a vitreoretinal surgeon who can also do some cataract surgery so that he can manage the vitreous base? SF-IOL requires both cataract and retinal surgery skills, but you have to choose wisely. It's an already complicated eye, and it's a more complicated than usual surgery. It's not a stereotype procedure. I think we have to think about safety first, and not I can also do. So scleral fixated IOLs should remain in the domain of vitreoretinal surgeons. And if he was a general surgeon, my friend, Professor Dr. Rajesh Sinha would have said, I want to do vaginal hysterectomy. Thank you.
Time's up.
Thanks, Dr. Gopal. That was a very good punch you gave. Dr. Rajesh, I'm sure you have a good counter for that.
Yeah, I would just share my slides. At the outset, I would like to thank Dr. Chitra for giving me the opportunity. And, I would also like to thank Dr. Gopal Pillai, who, gave some points which were really, strange, actually. So let me first speak about why I think that it should be, SF-IOL should be in the domain of anterior segment surgeon, because you go back to history, go back to people who have done great work in the field of SF-IOL. It was Enric Malbran in 1986 who gave the concept of transconjunctival scleral fixation of IOL. And what was he? If you just see the literature, he was a very good cornea surgeon. He has publications in ophthalmology, in very great journals in the field of cornea, like bilateral and unilateral penetrating keratoplasty, corneal dystrophies and keratoconus. And this Malbran is the person who is behind the concept of transscleral suture fixation of IOL. And then after 1986, a lot of modification, a lot of innovations have been done. And most of these innovations have been done by anterior segment surgeons. And the technique of SF-IOL became more popular during 2004, 2005 or 6, when this gentleman, who is considered as the pioneer in microincision cataract surgery, Dr. Amar Agarwal, who popularized the technique of SF-IOL or the glued IOL. And he has many publications in this field. Dr. Priya Narang, who is an anterior segment surgeon, has done quite a path-breaking research in this. I have also a few drops in the ocean of the research of SF-IOL, and I can tell you I am primarily an anterior segment surgeon. And I was allowed to do scleral fixation of IOL in the retina unit when I was posted for a short period, which Dr. Gopal was telling, because I was primarily an anterior segment surgeon. And all the residents, most of the residents, if not all, have been trained under me at RP Center, which is the biggest residency program in the country. So there's no doubt or debate that an anterior segment surgeon is more well-versed with IOL, the SF-IOL technique, understanding of IOL, nuances of IOL. And Gopal was telling that think about your dad. I would say think about your colleagues, your fellow doctors who will be more complaining. I have done SF-IOL in close to 10 doctors. And So the basic thing, I was just thinking that why Gopal is telling that, the posterior segment surgeon should be doing this technique, and why so many people, few people attach SFIOL with retina surgeons, because most of these cases have some of these cases have some dropped nucleus or dropped IOL, some complications. And these complications are better managed by VR surgeon, there's no doubt about it. So vitreous management, a complete vitrectomy can be done by a VR surgeon very nicely, lift up the IOL, and the anterior segment surgeon says that, okay, you just fix that IOL, whatever way you can do it, go ahead and finish it up, and so that I am free of the patient. So that is how the VR surgeon started having connection with the SFIOL. Now, just think about the steps of the glued IOL technique, and you can yourself imagine that whether anterior segment surgeon is more well versed with this or a posterior segment surgeon. You do a small peritomy first, which is better done by anterior segment surgeon, does pterygium surgery, does conjunctival flaps and corneal ulcers, etc. No retina surgeon does it. You do a lamellar dissection of sclera to create a scleral flap. That is also done by a cornea and anterior segment surgeon better than retina surgeon doesn't do it. Small anterior vitrectomy is required, not the total vitrectomy which a retina surgeon does. And that can be done through the anterior route or through the posterior route as well. And the pulling technique of, the pulling of the vitreous from the anterior chamber to do the small amount of vitrectomy in the PCRs has been described by an anterior segment surgeon, and that is Dr. Abhay Vasavada, and not by a retina surgeon. IOL loading, injection, haptic holding, exteriorization, tucking
60 seconds.
Intrascleral groove can all be better done by an anterior segment surgeon than a retina surgeon. And wound closure, of course, corneoscleral wound closure is done by an anterior segment surgeon only, and fibrin glue, of course, is used in pterygium, etc. So all these steps are better done by anterior segment surgeon. This study, which was published in Retina, states that in eyes with SFIOL, wherein PPB was done in comparison to anterior vitrectomy, there was more myopic shift and higher rate of IOL optic capture. So a retina surgeon only is claiming that. So in conclusion, I think the debates are done when there is some ambiguity. There is absolutely no ambiguity that the finesse that an anterior segment surgeon has to control the IOL is definitely better. And a VR surgeon is definitely more proficient in doing a full vitrectomy, and if there's a complication like a dropped IOL or nucleus. But if there's a routine FA for SFIOL, anterior segment surgeon is the one to whom one should approach. And lastly, I would like to say that, Gopal, you were telling that in Shankar Nitralaya, there are quite a large number of complications after SFIOL, and all these are done by retina surgeons. You take the data of RP Center, the complications are much less because it is mainly done by anterior segment surgeon. And lastly, but not the least, I had just noticed one more point, that it is not that only in post-RD or post-vitrectomy patients or only in the complicated eyes that the SFIOL is done. A routine FA also comes to you for so many reasons. The IOL is not put, and in such scenarios, it is the anterior segment surgeon who should be approached. And I am pretty sure that everybody will agree with these logic. Thank you very much.
Both of them have done well. Dr. Gopal, don't give up. Your last chance to rebuttal Rajesh.
Am I audible?
Yes, of course.
Yeah. So first thing Rajesh told about history. I think as far as he thinks, reminiscence of the barber surgeons are better than the surgeons now. So second thing he told that there were a lot of innovations because of anterior segment surgeons. The anterior segment surgeons required innovations because the previous models were not good, and it created more and more complications. And that is why more and more innovations and techniques had been there. Now, retinal surgeons were historically had more work in the vitreous in terms of retinal detachment, vitreous hemorrhage, all those things. And that is why we did not focus on this particular area, which that is why probably not a lot of work initially in the historical event. But now Dr. Rajesh Sinha tells about his good results in 10 doctors. I have no doubt that Dr. Rajesh Sinha is an excellent surgeon. If my dad requires, Rajesh Sinha will be the surgeon. But we are thinking about cataract surgeons across the length and breadth of India, which is a huge number, whether they will be trained adequately. some complications, he said, it's 20%. It's not just in
Minute
Shankar
up.
Netralaya for information, it's all over. Scleral flap, we do a scleral flap and keep an encerclage inside. So scleral flap is not we do a scleral flap to drain. So scleral flap, peritomy, all these are routine work. So what is critical here is the vitreous. What is critical here is any abnormality of the vitreous can cause a permanently debilitating blindness in this patient. So the risk of one side permanent blindness versus the other side some refractive error because the lens was not placed. What is critical? I think the judges can decide.
Dr. Rajesh, Dr.
30 seconds. The
Yes.
critical point is vitreous. I completely agree with Dr. Gopal, but we don't have to do a complete vitrectomy. We just have to do a little bit of vitrectomy, which can better be done by anterior segment surgeons who routinely do if there is a PCR, and it can be done through a pars-plana route described by an anterior segment surgeon, that is Dr. Abhay Vasavada.
So Rajesh was crisp. Dr. Mahipal, we look forward to your comments. I think you're muted.
Yeah, I think this is a debate just for the sake of a debate. I think ultimately it depends on the comfort level of an individual surgeon. After all, there is a particular level of skill and training that is required for any form of surgery. And if an anterior segment surgeon who used to do anterior vitrectomy is able to do these surgeries well, I think there's nothing stopping him. And in case he feels that he is not comfortable, he should pass it on to the VR surgeon. Now there are, Rajesh is sitting here. I can see Shri Ganesh here. He does a lot of these cases, etc. And for one, if I have to do, I always have my retina people, and instead of having to kind of start doing a particular thing, I'll pass it on to the retina surgeon. So I think everyone has to be very, very careful about one's own skill levels. And if you do not have the adequate skill, you should not do it. After all, we used to be just ophthalmologists, and ophthalmology has then been subdivided at certain institutions into subdivisions, while still there are comprehensive ophthalmologists who can do a little bit of everything. So at the end, I think the patient, whether it's your dad or your colleague or anybody, should be the most important thing. And you have to live with your own conscience and your own skill sets that are there. So you should not venture as an experiment. I think either of the two, if they are adapt to do it, they should be able to do it. But take your call, and it's your judgment call as to what it has to be done, because it has a little bit of both.
So on to you, Dr. Srinivas. I think we'll go on to the second case. Dr. Mahipal has clearly put across the right choice by the right surgeon.
Yeah.
Dr. Srinivas?
Yeah, thank you, madam. Good evening, everyone. So after a spirited and acrimonious debate by the two great giants in ophthalmology, so let's move on to our next team is Dr. Himanshu Mehta, premium cataract surgeon who has the best of the Mumbaikars at his doorsteps. When I say best of the Mumbaikars, it includes Amitabh Bachchan as well. And he's fighting against another doyen, Dr. Satyajit Sinha, who presently is a member of ARC East Zone, but in futuristic, probably a chief minister of Bihar. So when I say as a minister who clearly knows about winning the bread. So the topic of the debate is the premium surgeries is the way to go against the fortune lies at the bottom of the pyramid. Over to Dr. Himanshu, sir, please.
Thank you, Dr. Srinivas. Wonderful to be here in this podium and speak to everyone. I would say the topic given to his premier surgery is the way to go. But I would quote Dr. Mahipal just a minute back when he said that there is nothing premium about premium. Evolution of science and technology and meeting patient needs and expectations, and what you can give them so that they can see very well in this world is the need of the hour. We talk premium with respect to money. There is no money involved in science and technology. Science and technology will be at the forefront of human life in the years to come. This was said by Albert Einstein in 1944. You'll see how important it is that it is nothing to do with premium. All this is a necessity. Innovation was never a premium. It is a necessity. Now, let's see how the world progressed across in every field. We are not talking about luxuries. We are talking about how science evolved, how we moved from the dabba phone to the cell phone. It's not a luxury anymore. The smartphone gives you so much. Life has changed so much. There's so much innovation. There is so much of answers into that. And this is what I'm trying to tell you, that there's nothing premium about premium. What used to be premium is now a necessity at every given point of time. Now, over the years, we have told patients and overpromised them, no injection, arey kuch nahi, no injection, no pain, no patti, arey fata, kal office ja sakta hai. Kal sab dikhega, WhatsApp bhi dikhega. So now patient by evening, if they can't read their WhatsApp, they are going to kill you. That day, look, your surgery has gone now. Now, the money doesn't come. Please don't misunderstand. Even if it's a monofocal, free charitable hospital patient, he expects it is birthright after cataract surgery that he should see everything. So we are caught in our own web in the big talks over the years. And fortunately, science and technology has helped us to go ahead and go further. And health and vision, there is no scope of a compromise. There is no premium element in this. Is it a necessity? I dislike the word premium. Now look at this picture. Is this what you want on the left side, or is the right side more important? It's absolutely glasses-free vision. Is that a luxury? Is it a premium? Not at all. It is a necessity. So look at the technology. We have seen a Phakic glasses once upon a time. Is that what you want for people? By saying that, no, this is premium, not giving them glasses is not a premium. Come on, let's walk into the modern world. ECC 180 degrees with stitches and huge 180 degrees, against the rule astigmatism of 3 degrees plus. Is this considered premium? No, it is a necessity. So absolutely nothing was a premium at all. In your car, you have that roller car you used to have. That is not a necessity. And now here, look at that. We as ophthalmologists, we just discussed, you have the anterior segment surgeon, you have the glaucoma surgeon, you have the retina surgeon. You mean to say somebody spent 10 years and put in retina surgery and glaucoma or oculoplasty? They are premium? No, it's a necessity of the need of the hour. Whoever is more qualified to give the best to the patient. You know what happens, friends? As doctors, we have undersold ourselves. The word premium comes from these multinational companies who want to sell the lenses. When we started with lenses, ultraviolet was a big thing. They used to charge us for that. Then they used to charge us for putting achromatopsia, then achromatic lenses, then aspherical lenses. Now tell me, is it not a birthright of a patient? Would you use aspherical lenses today? Aspherical, toric lenses, square edge technology, foldable lenses, hydrophobic. Now, if money put on one side, is it not the need of the hour? Is it not what we need for every patient? Yes, we'll progress to preloaded lenses tomorrow. Is this a great amount of premium? Not at all. Why did they not give it to us? Well, their fault. And we always accepted very coolly. We kept on doing our education very well, but none of us ever said that we were premium surgeons. We all were humble human beings. And the pharma sold it to us as premium. They said, no, this is premium, so make more money. So their profit was 10,000 times. This is where now you have an astigmatic patient. Now, what are you going to do in an astigmatic patient? Will you use a toric lens or you will just use a regular lens? Yeah, sure. But if you have a toric lens available, why wouldn't you? Is that premium? Not at all. It's an indicated surgery.
60 seconds.
Yeah, right. I'll be right. So laparotomy, today the laparotomy and laparoscopy, it's a no-brainer that you want a small incision, micro incision surgery is the way to go. Next slide. So the point is, life is a matter of perception. What eventually science and technology wins. What we want is the ultimate thing for the patient, that what we want all patients to say. Look at this.
How are you feeling?
Fantastic. I'm so happy. I say I'm the happiest person on the earth.
Yes, friend, this is what we want from patient. This is not premium. This is exactly what we have done all our life training for, to give them the best. We trained for 30 years. This is not premium, and we are not charging any premium for that. The premium word was introduced by the pharma. Let's put it on one side. It's technology, updates in science, and how we put our technology and surgical skills to give the best to the patients. I leave this to my opponent now.
Thank you, sir.
Time's up.
Hasina Saab, you have a tough job to do now. So let's hear you out beating your opponent. Go ahead, please.
Do you see my screen?
Yes, sir.
Okay, very good evening to all of you. I have been given the topic of fortune lies in the bottom of the pyramid. My worthy opponent has spoken just now, Dr. Himanshu, and he showed the picture of a plane. And the debate is here whether a business class is a must or not. The debate is whether you actually need an iPhone 11 or not, iPhone for a cell phone. Now, Vision 2020 was one of the questions which we used to get in our community ophthalmology question. And it turns out that we didn't have a vision of 2020 at all of what was going to happen in 2020. We have all fallen on our face in these COVID times, and propagating premium IOLs is going to make matters worse as regards reduction in the incidence of preventable blindness. We took the Hippocratic oath, serve the humanity. But if we are going to propagate premium IOLs, I'm not sure if how much of the humanity we can serve. There is one thing in COVID times that it has taught us. We have to respect what is required most and not what is a luxury. Cataract means different to different people. For some, it is fine print is important. For some, view of the field in the village is good enough. Now, India is the largest consumer of IOLs in the world, and the premium IOLs are a fraction of it. Population of nearly 1.5 billion now, and we have to think about everybody. We cannot think about a select few. And the number of cataract surgeons that we have are limited to less than about 10,000. India is home to 1/3 of the world's blind population, and how can you talk only about premium IOLs and the elite? One of the statements that Sir said in the middle was, money put to one side. Money cannot be put to one side because it is one of the most important things. What Dr. Srinivas is saying, Sir is treating the who's who in Maharashtra, but more than 50% of the population of Maharashtra lives in rural area with agriculture as their main occupation. So monofocal is the way to go for India. The cost of SICS is about $20, whereas if you are going to do flax in our clinic with like Dr. Himanshu's, it's anywhere between more than $500. So premium IOLs are a luxury for privileged few. What you see on the top is what India is, and they cannot afford the trifocal IOL that you see below. Now, we cannot just go running behind and copy what they are doing in the West. We have to have our own systems of reducing the incidence of blindness. Indeed, fortune lies at the base of the pyramid. My submission is not against the science of the premium IOLs, which Sir was saying. But its implementation in the country of 1.5 billion people. Progress is not about science, it's all about science, but it should not have a road roller effect on our common masses. Let's talk about the turnover of Arvind Eye Hospital, Disha Eye Hospital. Dr. Devashish Bhattacharya is sitting in the panel. Dr. Sitapur Eye Hospital, Chitrakoot. I'll just tell you, leave alone how much you are making money in the premium IOL sector. Disha Eye Hospital has invested in the past few years 100 crores in West Bengal, and they have a module for it. Arvind Eye Hospital, it reaches out to all reaches out and serves to all those who are in need. Arvind Eye Care started as an 11-bedded eye hospital, and now they have seen over 40 million patients. Unbelievable. And what they do not depend on donors. Their net profit, and this is from a few years back, was $8 million. Forget about changing it to rupees. I will lose count, but this was in 2010. I think it must be $15 million now. Over and above all that, when you have to put premium IOLs, you have to put in manpower, you have to put counselors and counseling for all these things, and then you have to deliver that. That burden is on the patient, and over and above that, the surgeon also has a lot of burden in buying Pentacam, IOL Master 700, and for the rest of his life, he will keep returning all the EMIs in the bank.
60 seconds.
All that you have done, you still have to tell the patient that there'll be halos, glare, there may be there may be contrast decrease, so on and so forth. It is much more difficult to manage refractive surprise in patients with premium IOLs as their expectations are very high. And then you have a list of things where you cannot put these premium IOLs with those who have ocular surface disease, keratoconus, monofocal IOLs, those who have low endothelial cell count, macular disease, diabetic retinopathy, patients who have unrealistic expectations, and those who have issues with the weak zonules, whose angle kappa is more in pediatric patients, in small pupils, in patients who have had refractive surgery, and those are the patients in future who are going to come more to our clinics. And just a food for thought, in all those young patients who we are putting the multifocal and bifocals, after 30 to 40 years, all these patients, God forbid, if they have ARMD or corneal pathologies, how will this trifocal and multifocal act is something that we should be thinking about, or will it be the monofocal patients who will fare better? Thank you so much for your patience here.
Thank you, Sinha sir. Himanshu sir?
Yes.
Candidate and the universal thoughts of Dr. Sinha. So your rebuttal, please.
Yes, sir. He just spoke exactly for me. Fortune lies. So he kept talking about money. You know, by vertical integration of Arvind, they have made more money than a premium IOL surgeon can ever think of doing, because he's using science technology to give the best to the patient. He's spending money from his bloody pocket to see that the patient sees well. Every point, Disha out of 100 crore will make 500 crores. And I will lose money because the equipment supplier makes money. That's what, friends, I'm trying to tell you as surgeons. We are walking into a wrong dead trap of saying that fortune, it's not the fortune. I'm not talking about money. Let's talk of science. We are talking only about progress and evolution. So giving the best to the patient, which is his birthright, should be the basic thing that we are looking at. Toric IOL, multifocal, it's immaterial. Glasses-free vision, toric, and seeing very well in this life for the rest of their life. And sir, for that matter, a multifocal with a plus lens would give rise to a telescopic lens for an ARMD patient. This is, I would wind up. Thank you for speaking for me. That exactly in trying to have the volume game, we are trying to make more money. I'm not looking at money. Sorry.
Thank you, sir.
That is what he's exactly saying.
Thank you, Sinha sir.
The money, because tomorrow if I tell him to do a premium IOL surgery for $20, he will not be able to do it. And we are talking about 1.5 billion people, and how many of them can afford going to Dr. Himanshu for a premium IOL surgery? If sir reduces his cost to $20, I will accept defeat in this debate.
Half a second. Friends, it is not a fight between doctors. Unfortunately, if we all get together and tell and force the pharma to give the right kind of substance to us at the regular rate, you know, like the PMM lens, which used to cost a bomb earlier on, if we can get all lenses at that rate, if we fight with them and give it to us, we'll give our patients the best. Thank you so much.
So after the parliamentary fight between the big guns, I think Debashis sir was slightly confused. Was this topic on the premium surgeries or on Disha? Anyway, it's a good point. We made both of you. So I would like to, Namrata madam, your thoughts, please.
How would you like to just like Dr. Mahipal sir said that there is no debate, I would also like to say the same thing in the sense that primarily it is determined by the affordability of the patient. So if the patient is able to afford it, and if the patient wants to have premium IOL surgeries, then that is the way to go. And now, because everybody is so much net savvy, you know, they've already Googled everything and they will come and tell you they want it. Having said this, there is another set of patients who cannot afford, or who can afford less, shouldn't say cannot afford, and probably if given an option, and if they are able to afford it, or like NHS in UK, you make everything paid by the government, I'm sure all of them would, you know, want to go in for premium intraocular lenses, and nobody will say then that, you know, they are okay with the monofocals or whatever. So I think it is all about affordability. It is more about patients than about us doctors. It is about their pockets and less about our pockets. And from our side, it is our convincing ability, how much we can convince them.
Thank you, madam. Over to Chitra, madam, please.
We shall go on to our next team, which is quite an awe-inspiring team. We have our Bangalore Prince Charming, Dr. Sri Ganesh, against a Coimbatore man to be reckoned, Dr. Ramurthy. And they have a real debatable score here. Immediate simultaneous cataract surgery against sequential being in the interest of the patient. Don't you think the air is sizzling already? So Sri Ganesh, we are looking forward to what you have to say. Reasonable or unreasonable is what Ramurthy would decide.
Good evening, dear friends. And I would like to thank the ARC for giving me this opportunity. Are my slides visible? Is it clear? Oops, sorry. Let me just, it's just running. Okay. Okay. So let us start. My topic today is immediate simultaneous bilateral cataract surgery. And I have no financial interest, but a lot of interest in this topic. And in today's time, COVID times, let us look at what is the news. The latest conference, the biggest conference was the virtual ASCRS, which happened. And then the ocular surgery news just reported this, that surgeons should consider offering immediate sequential bilateral cataract surgery. And there was a talk by Huck Holz, cornea specialist at Kaiser Permanente from California. And he said immediate sequential bilateral cataract surgery results in half as many operating room and office appointments when compared with traditional delayed surgery. And it requires less personal protective equipment for staff. So the cost saving because of the PPEs is much more, lower cost to the clinic, and leads to less crowded practice, parking lots and waiting room. So in today's world, especially, we will have to consider immediate bilateral cataract surgery. Let us look at the benefits. First, let us look at the benefit to the patient. Suppose you're using general anesthetic, then whether it's an adult or pediatric case, then with one anesthetic, you can complete the surgery on both eyes. And there was a problem giving a block, because if you give a block in both eyes, then that was the thinking before. But today, most cases of cataract are done under topical anesthesia. So bilateral cataract surgery is fine with the patient, and then the patient recovers immediate. So improved visual function also is one of the benefits. One-step visual rehabilitation, and there's no anisometropia between operations for patients who have refractive errors. And you can just prescribe one pair of new glasses 2 to 3 weeks after the surgery, bilateral surgery. You don't have to keep changing the glasses, and lesser number of post-operative visits. So less crowding in the OPD and less cost to the patient. To the hospital, the advantages: there is only one pre-assessment visit. There's only one admission for surgery. So this reduces the time. It reduces the amount of PPE, and it also improves the efficiency in the operation theater, and it's more efficient use of the OPD and clinic. To the society at large, shorter waiting list for surgery and clinics, because many of the countries like UK and all that, they have large waiting lists. So this will cut down their waiting list like anything. And accompanying friends and relatives need not take off time again and again. It's less demand on hospital transport services. Now we provide transport to patients who want cataract surgery. And this really helps, because in COVID times, especially when there is difficulty in transportation. Coming to convenience and cost, reduction in medical visits contribute to the convenience factor and cost savings. So the patients also are more for it. And older patients may have to arrange for caregivers. They may have their children to take off from work, and the need for 2 surgeries doubles the expenses to the caregivers. And caregivers actually prefer that it be done immediately. And then there is also a publication by Arshanov that comparing immediate sequential bilateral cataract surgery versus delayed surgery and the potential hospital cost savings. And they found that there was a 32.4% reduction if you do bilateral simultaneous cataract surgeries, which is a huge chunk of money. And Levo's estimate, when he mathematically calculated, globally, if bilateral cataract surgery is done with a ratio of sequential surgery 1:1, even 1:1, you will have a saving of $100 billion US, which is a huge amount. And especially in today's time with the global recession, economic recession, this is a huge amount. $100 billion is a huge amount. And visual function, stereopsis is disrupted in the time between the 2 cataract surgery. And when eyes continue to function monocularly, patients lose depth perception, visual rehabilitation is delayed. And there's a paper also which says that if you do sequential surgery, it takes 4 months for the second eye to recover, whereas with immediate bilaterals, it is immediate. Coming to our own publication in IJO, where we did immediate sequential bilateral cataract surgery. This is one of the largest series, 2,470 eyes, a 5-year retrospective study. And we looked at the results and complications. If you look at the results, you can see that post-op spherical equivalent, more than 92% has less than 0.5%, and 99% had less than 1 diopter of spherical equivalent. So biometry is not an issue nowadays. And this is the same thing. You can see 92% had spherical equivalent of less than 0.5%. And complications, only 0.44% PCR, 0.16 vitreous loss, 0.08 CME, prolonged iritis 1.3. So the complication rates are quite low. And Arshanov also noted that rates of unilateral endophthalmitis after simultaneous bilateral cataract surgery were compared to or lower than for unilateral cataract surgery. This is published in Current Opinions in Ophthalmology. So this is all scientific research, and also compared to bilateral delayed sequential cataract surgery, there's no evidence that immediate surgery was associated with worse postoperative vision or refractive error or an increased risk of complication. This is scientific data out of 13,711 eyes comparative study. So there are a few keys to success: competent surgeon with confidence, with a complication rate of less than 0.5%. Selection of cases also are important. Best sterility equipment, you can't do it for everybody. So when procedures like LASIK, multifocal IOLs, ICLs can be done bilaterally, while not bilateral cataract surgery, amount of patient inconvenience and discomfort is greatly reduced, and effect of second eye syndrome is abolished. Especially in today's times, dear friends, we have to think about bilateral immediate cataract surgery. And to do bilateral surgery is basically a mental block rather than any other barrier. And I challenge my opponent to prove scientifically with scientific data that delayed surgery is better than immediate bilateral sequential surgery in selected cases. Thank you very much for your attention.
Dr. Ramurthy, you have to give your best hit. Sri Ganesh has really reeled out a lot of statistics.
Ganesh, at least stop sharing your screen. Allow me in.
There you go. All yours, Ram.
Great talk, Sri, as usual.
Chitra told me to prepare for it.
Oh, yeah. The same thing she told me too. Well, I mean, thanks AIOS ARC for allowing me in. And I'm definitely for sequential bilateral cataract surgery, but I'd like to have a delayed sequential bilateral cataract surgery. Let me offer a scientific explanation for doing this. What are my concerns with ISBCS? It's bilateral endophthalmitis, bilateral TARS, bilateral cystoid macular edema, in case we have missed out on the macular evaluation, or something which can even occur postoperatively de novo. And we are unable to get the refractive insight from the first eye, and decreased reimbursement for physician in certain healthcare systems. These are a collection of reports, scientific reports, papers which have been published of bilateral endophthalmitis which have occurred after ISBCS. Obviously, the numbers are small, and almost all these reports were secondary caregivers where the endophthalmitis has occurred somewhere else, and the patient has gone elsewhere for the treatment. So obviously, just because the numbers reported are less, that does not mean there is no occurrence, because many of them might be going under the radar. Getting bilateral endophthalmitis after bilateral cataract surgery is nothing to be proud of, and nobody is going to be talking much about it. So obviously, this does occur, and these are some of the pictures that I have taken out of the papers that were published. Leave alone statistics, leave alone numbers. I do not want to face this kind of a situation even once in my professional lifetime, especially nowadays, now that we are talking about prelex, talking about patients with 6/6 vision. Obviously, even if one patient in your entire professional lifetime ends up with a situation like this, that's totally unacceptable. Let us look at a scenario, a reported case, 80-year-old Parkinsonism patient with dementia and cataract, preoperative visual acuity of 20/50, 20/60. He was from Northern California, but for reasons went over to Mexico, where an uncomplicated in-the-back single-piece intraocular lens surgery was done. And night after the surgery, the patient was found in the restroom, confused and covered in his own stool. Maybe it was a matter of convenience for him to go over, save cost-cutting, and then a demented patient for him to travel, etc. is a difficulty, and that's why perhaps the bilateral cataract surgery was done. But imagine his plight. It was initially diagnosed as TARS, subsequently underwent vitrectomy on the first postoperative date, diagnosed as Pseudomonas aeruginosa, and was shifted to Northern California for a repeat vitrectomy, ended up with bilateral phthisis without pain. Obviously, as somebody who started out with 20/50, 20/60, and a Parkinsonism dementia is a terrible state to be in. You might say it's anecdotal, but we do not want to face this kind of a situation ever again. Obviously, we are a population of 1.3 billion, and we cannot escape from the fact that community ophthalmology would continue to deliver cataract eye surgery. And obviously, these patients are not too well educated, hygiene is not so good, and on and off we hear about cluster endophthalmitis. Imagine a cluster endophthalmitis occurring in a scenario where bilateral cataract surgery has been occurring. Leave alone the harm that will cause to that particular practice, I believe the whole world of ophthalmology will be in turmoil. The other factor I will be concerned about is bilateral TARS that can set in. Obviously, less devastating than bilateral endophthalmitis, but equally of concern, and sometimes it could lead on to significant visual morbidity bilaterally. And at the other end of the spectrum, in case you're dealing with premium intraocular lenses, then refractive insight from the first eye for optimizing refractive outcomes after bilateral surgery is almost always lost. It's every patient of mine, whether it's monofocal or multifocal, I always counsel for second eye surgery. I tell them that it is second eye surgery which is going to give you best possible vision. Look at a scenario like this. These are all screenshots of my actual patients. Underwent LRCS with Symphony multifocal and excellent vision for distance and intermediate, but required a +1 diopter for the near vision. Obviously, unhappy patient. So we went ahead and implanted a Technis plus 4D in the other eye. Mix and match. Look at this scenario where you find that what was required was a plus 0.5 diopters. So in this situation, we just did a mini monovision, titrated the power of the eye in the second eye so that bilaterally implanted, they did well. Another case, you see EDOF toric multifocal that has been implanted, but again, there is a somewhat inadequate near vision in the unhappy patient because plus 1 diopter. So the second eye goes ahead and receives a toric trifocal lens, which obviously optimizes the kind of outcome that this patient has. And coming to the reimbursement as such, 100% for the first eye and 50% of the second eye is what is there in the US. In Japan and Israel, no reimbursement of the second eye. In most countries, when bilateral surgery is done, reimbursement of the second eye is somewhat less. Maybe it's not so in India because it's not widely practiced. But once it becomes a norm, obviously insurance companies are going to look into the reimbursement. And what's our last of my slide? What is our protocol when we do delayed sequential bilateral cataract surgery? Patient walks in for a complete evaluation, discharged soon after the first eye surgery, reviewed a week later, and evaluated, or at the same time, the second eye is operated. And only if there is a doubt about the outcome in the first eye, any tests are done. And the patient goes back and comes back only for glass prescription bilaterally a week or 6 weeks later, if at all is needed. We have cataract cowboys, I think, with the only need for bilateral surgery is for the economics of the doctor. So Ganesh, you are an excellent surgeon. Patients are always going to come back to you for the second eye surgery. Don't worry about it. Keep the patient's concern as your primary concern. Thank you so much.
Dr. C. Ganesh, I think
Ram, I think it's finally about the money because you're worried about the reimbursements primarily, and you make more money than me doing delayed cataract surgery. So let me give my points. The first, he showed a patient, 80-year-old patient with dementia who was covered in his own stools. Of course, if you go into your own stool and put your head into your own stools, or if you go into the sewage plant, then the risk of endophthalmitis is more. So case selection is very important. I am a member of the International Society of Bilateral Cataract Surgeons. There is a society like that, and the society has protocols. I couldn't talk about it, but it's in our paper, which we published in the IGO. So you will have to, case selection is very important. This patient was not an appropriate patient for bilateral cataract surgery. He didn't have caregivers. He was alone. He was not taken care of. And if you have infective material in both your eyes immediately after cataract surgery, what else can you expect? So that was a one-off case which you cannot project. The second is you were talking about refractive errors. Now, in our case, 92% had spherical equivalent of within 0.5 and nearly 99% within 1 diopter. So the accuracy, the refractive accuracy is very good with today's biometry equipment, formulae. So that's not a concern at all. And thirdly, you said you do surgery after 1 week. So can't you get endophthalmitis after 1 week? Delayed endophthalmitis, fungal endophthalmitis, sequestrated endophthalmitis, all of them occur after 3 weeks. So what is the justification in doing the second eye after 1 week? That means you have to wait for at least 3 months. If you want to delay your second surgery, that means your protocol is not okay. You're just doing it after 1 week so that you get better reimbursements. That's the whole reason. And I rest my case. Thank you.
I think you have to take your chance to save yourself.
I think, as far as most of the elderly patients are always at risk of things going wrong, this was not just a one-off case. I presented a whole series of cases which have been reported in the literature of bilateral endophthalmitis. Obviously, the incidence of what has been reported is quite small. And obviously, in expert hands like yours, in excellent premium setups like yours, it might work well. In a larger scale, in larger practice, I am also aware of the what has been put forth by the Association of Bilateral Surgeons. But it's such a large paper. I'm sure that many of the surgeons who are doing this have not even gone through it and not adapting to it completely. And as far as refractive inaccuracy is concerned, none of these patients which I alluded to, the 3 samples that I showed, had anything bad refractive outcome. It was not bad biometry. Basically, what I want to drive home is we don't aim at emmetropia in both eyes. Depending upon the refractive outcome in the first eye, I titrate the power, whether I need a minus 0.5 or I change the type of intraocular lens that I'm going to put in, because it's the convenience, the comfort level of the patient is what matters to me. I want a happy patient at the end of the surgery. I might leave the first eye with 6/6 N8 and other eye with 6/9 N6. And I think the second eye surgery obviously offers me an excellent opportunity to titrate the kind of power, the type of lens that I'm putting in. And yes, you can't diverse the commerce of ophthalmology from the science of ophthalmology. And you are in that game, I am in that game. And if tomorrow the reimbursements drop because you're doing the second eye surgery at the same time, I'm sure you're also going to go ahead and do a second eye surgery a week apart. And most of the complications, whether it's endophthalmitis, stars, etc., present within a week's time. And obviously, you can't wait endlessly for these things to present. And I believe 1 week is most often a reasonable time period. Thank you.
Yeah, I agree with Ramurthy for certain things, like case selection is important in the surgeon also. It depends upon the surgeon. So your complication rate has to be less than 0.5%. Your rate of endophthalmitis has to be less than 1 in 15,000 if you want to do bilateral, and it has to be in a premium setting. You cannot do it in a camp setting. We also do camps. We do almost about 10,000 surgeries every year in our camp settings, but we never do bilateral simultaneous cataract surgery in a camp setting because you do not have the facility for that. So that is very important. What the take-home message is, if you want to do bilateral cataract surgery, your case selection has to be good. As a surgeon, you have to be very competent. Your OT sterilization techniques have to be absolutely on, and your biometry. So these are the things. Thank you very much.
I think both of us are debating not because the sake of debate, but because we passionately believe in what we are saying. And I think that applies to Sri Ganesh as well as to me. I believe that I have a premium setup, but still I don't do that because I believe that when I titrate the kind of surgery, the type of lens that I implant in the second eye, I end up getting much better results.
Dr. Gaurav, both of them would go on and on if left to them. I need your conclusive thoughts on that.
Okay,
Dr.
Chitra, you put me in a. Can you hear me?
Gaurav is confused.
Can you hear me?
Yes, sir. Please go ahead.
Okay. So Dr. Chitra has put me in a very difficult situation. You know, I'm caught between the devil and the deep sea. Close friend Sri Ganesh, close friend Dr. Ramamurthy, and Dr. Chitra has invited me. If I make a mess of this, I'm not going to come into any of the ARC debates in future as a panelist. So anyway, let me try to do my best.
Remember, I'm the cowboy with the gun.
I think both of you have done an amazing job, and Sri Ganesh has made a very strong point for.
You just need to tell who sizzled more.
So both sizzled so well, but Sri Ganesh made an excellent point with all the things that he said, and they all make a lot of sense, and they are beginning to make more and more sense as times are evolving, and we are moving into a newer era, especially with COVID, and the situation is changing where more of insurance, and like the US now, they have more and more simultaneous bilateral because the caregivers are also the insurers, and they prefer to cut costs and perform simultaneous surgery, less visits to the hospital. All that stuff holds true. Something which I did, and as well, because you have, in your controlled environment, as you said, and in fact, the last part that you said made all the sense that, in your controlled environment where qualities and everything is excellently controlled, you are able to offer this, but not in your charity setups where, there is that risk where, there can be small compromises. So you have to have the best of everything, and only very few setups would qualify, or very few surgeons would qualify, where with proper case selection, they may be able to do this. And yes, it is definitely to be looked into as one of the options. I've done it for a few cases myself, where there was a mentally retarded patient who could not be brought in for surgery a second time. So under very controlled things. One place where, Sri Ganesh, where I felt that, PPE kit we cannot save on. If we are doing simultaneous bilateral, I would definitely change the whole thing, the sets, the PPE kit, everything should be probably changed. You could even do it like one case in the morning and the other one after 2 hours, with a totally new kind of, on the same day, but in different sittings. That would make sense. But that said, I think my personal school thought, and I started thinking, have I become old school of thought when Dr. Ramamurthy was speaking, that, I feel that all the points that he raised were also very valid, and I agree with those, because, second, I also feel that I can titrate my refractive results a little better. Biometric surprises can be managed. Multifocal patients can be managed a little better. Risks are obviously a little less. Yes, with modern technology, endophthalmitis are seen very rarely with intracameral antibiotics and everything. Yet even that one patient where you might get it. So I think we are moving in that direction, and the future may show us more and more simultaneous, immediately simultaneous bilateral in select situations, in select setups. But that should not be the take-home message for the Indian audience in sitting in all over the country, where maybe if not 90, 70 to 80% of our surgery is done in, setups which may not qualify for a similar thing, and the surgeons may not qualify, and the meticulousness may be an NBHS approved setup like yours. So I think I've made my point, and I think both ways are good, but you have to be sure what you want to do.
Yes, Dr. Gaurav, you did put it across, and I think people have to be very intelligent and decide what is best to them, whether it was the first debate or the second. The idea of the whole thing was for us to think very rationally and do what is right for our individual setups. On to you, Dr. Srinivas.
Yes, madam. So, dear friends, after the super colossal debate between the two superstars, Dr. Sri Ganesh and Dr. Ramamurthy, we'll move on to the next team of two young guns attacking the issue. Dr. Nishant Madhivanan, the dancing hero who dared the worst challenge from Chennai, versus Dr. Samaresh, and another elegant and charming person from Jaipur who could find his way out of anything. So the debate here is anterior vitrectomy is intuitive for the anterior segment surgeon versus the pars plana makes the most preferred approach. So over to you, Dr. Nishant. You go first, and we look forward to a winning debate from you.
Thank you. Thank you so much, sir, for the wonderful introduction. I'll just share my screen and is it seen, sir?
Yeah, please go.
Yeah. So yeah, my time starts. So I don't have any financial interest, but definitely have the finance interest of what Samresh has. So you have told it very perfectly what an anterior surgeon should do, the anterior vitrectomy. So definitely I cannot defeat Samresh in two things. One is his personality, looks, and definitely his grants and help from Alcon company. So we all know all these movies from the past. They've always said, never poke anyone from the back. And if Samresh is planning to do something like this, definitely that's not something which I can win. It's like telling a corneal segment surgeon, showing him this and say, see the layers. Even if you mark out the layers, I'm definitely not going to know which layer is what. So coming over to the procedure, it is so simple when you do it anterior. The fear of the vitreous loss for any anterior segment is there. You just have to put some triamcinolone, make sure that you stain the vitreous properly, and always you will have some in the wound. There is no vitreous loss without it being in the wound. So always start from the section. So you can always do this vitrectomy only if you do the limbal approach. And then when you start going in, either with the 23 gauge or 20 gauge, do it near the iris. And then for vitrectomy, actually, they say that you can go below. There was a false misconception that the vitreous comes forward. But as long as you cut and aspirate, which I'm sure Samresh also will agree, the chances of vitreous coming forward is definitely very less. And you can even sweep through the main port, go all see the vitreous which is attached at the section, and also you can do the vitrectomy as well when you go through the anterior approach. I'm definitely sure reaching the anterior segment is going to be tough. In places where you have some remnant cortex or anything, it is also an easy approach because it is something similar to the bimanual aspiration that we do. So you can see that the remnant cortex and all which can be removed even anteriorly, and you can go little to the core of the vitrectomy base. You don't have to go too much back, and you definitely have to see what you cut. So I drive this kind of a red car with this machine is what I have. I'm definitely sure with Samresh's machine and his car which he uses, he will always get the 23 gauge vitrectomy. He should know that all of us don't get the 23 gauge vitrectomy for all these machines. So with the side port which we normally use, a 20 gauge will snugly fit. All of you must agree that you should have a snugly fit side port for the vitrectomy. And if at all you do a side port and make it a 20 gauge, you definitely have to suture the sclerotomy or put a trocar. So this is also where you have a PCR, you can do it at the iris plane, and then you can see that the PCR does not extend, which is something which they say there are chances of extending. And to also note that when you also place the IOL, and then if you want to wash the visco, you can actually go anteriorly behind, through the limbus behind the IOL. While washing the visco, you can also cut. And we have moved over from the micro incision cataract surgery to what Samresh is going to talk about, the multiple incision cataract surgery. And we all know that when you want to have, after a vitreous loss, the first thing, this is done by a retinal surgeon, you can see the hypotony. This fear, if you get while doing, trying to put a trocar or any port is going to be definitely tough for an anterior segment surgeon. Let us all be sure of that. We are not posterior segment surgeons. And putting this amount after a hypotony, you will definitely make sure that you damage the retina on the other side, or do an optic nerve sheath fenestration by injecting the trocar. And not only one, then you decide your infusion port is there and you need another. So you make it multiple incisions. So when we don't have proper literature, finally it comes down to the crowd's choice.
I was the best because the crowd loved me. When the crowd, when your freedom.
So there was a poll, audience poll, which was done in ASCRS, where they showed that 70% of them performed bimanual anterior vitrectomy. Samaresh can actually have that 6% of the people who actually performed bimanual pars plana vitrectomy. And coming over to the complications, yes, this is the most important. When you go anteriorly, wow, iris tissue injury. I think there is nothing more to add to it. And when you go pars plana, there you go, the retinal tear, the detachment, the hypotony, the effusion, the hemorrhage for the endophthalmitis. I'm sure that all these complications are possible even in anterior vitrectomy. But when you have to choose for the patient's benefit, the risk of anterior vitrectomy through pars plana, when it is increasing, why do you as a surgeon want to give an increased risk of problem to the patient? And sometimes I'll say always fight me anteriorly, never go behind my back. Because if I have to teach you a lesson, I will go and whatever means to teach you a lesson in the proper way. So thank you, Dr. Chitra Madam. Thank you, AIOS, for giving me this opportunity.
That was wonderful, Nishant. Very good.
Wonderful. So over back to Dr. Samaresh. So we all know Dr. Samaresh is from Jaipur. Dr. Samaresh, we want you to pilot this debate. And we all know what a pilot can do to any stable government, right? So just go ahead, Samaresh. We would like to look forward to your punchline.
So first of all, at the outset, I'd like to thank Dr. Srinivas for a beautiful introduction, Dr. Chitra for inviting me for this debate, and I'd like to acknowledge the presence of one of the teachers who shaped my career, Dr. Meenakshi, who's also presenting today. It's been an honor. And Nishant, I love the fact that you rehearsed the talk so well. You know, I mean, you had to work hard for it while I just made my slides listening to you. So it's very important to understand. I'm just going to discuss simple science for, if you had just attended anatomy lectures, you would know. First of all, in techniques, you never do anything through the main port. So forget about pars plana. When you talk about limbal, don't touch the main port. And you are vitrectomizing on the main port, which is something you don't want to do because it's like a lip. It will open and it will prolapse more vitreous. Separate the irrigation from the aspiration. That's the first thing. So that I think you didn't cover, so I thought I'll bring it up for the crowd. But we are not crowd and we are here to teach because we are a little class apart. So the question right now, I understand, is whether we should approach the vitrectomy, the PCR through a limbal or a pars plana route. Now, why a limbal route? We all know limbal is familiar territory. That's what our teachers taught us in our time. They said, no, don't go limbal way, don't go the pars plana way, people will get confused. And since then, it's been the norm. And so everybody's been continuing. The problem is, as a cataract surgeon, our goal, if at all, is to fix the IOL inside the capsular bag, in which, if we can, because that is what we have committed to the patient when we started the cataract surgery. Typically, a posterior capsule tear would enlarge. So Nishant brought about, sometimes the tear doesn't enlarge, and that's because the tear is so big already that there's no more place to enlarge it at all. So you have to look at the size of the tear and keep it small. And sometimes when you enlarge the tear, you cannot fix the lens where it's supposed to be inside the capsular bag. Pars plana, what's the good part? I'm discussing pars plana vitrectomy from a cataract's perspective. So most often you can avoid enlargement of a posterior capsular tear from where it started, and I'll show you how. You can do a thorough vitrectomy. And the consequences are minimal because right now, as I said, the damage is already done with the posterior capsule rupture. You have to save grace right now, put the lens in a committed place, and sensibly refer the patient to a retinal surgeon for the further evaluation. The problem is we are scared because it's unfamiliar territory. We are intimidated because it's all pars plana and it needs an elaborate setup. That's what Nishant said, but I completely disagree with what he said. To understand, when you do a limbal vitrectomy, you're putting an upward drag on the vitreous body. So small PCR that started causes more and more vitreous to prolapse, finally enlarging the PCR into a ragged, large, big one, which you are unable to salvage, and then you'll have no choice but to put the lens in the sulcus. Compare it to a pars plana, where the irrigation is limbal, but you approach the vitreous from behind the posterior capsule. You drag that small vitreous back into the posterior compartment, trying to keep the edges of the PCR nice and controlled, and the PCR would typically not enlarge, and then you can later tackle this PCR by one of many ways, like a posterior capsular excess. Looking at it scientifically, If you look at this, we are doing a very slow motion video photography using 300 frames per second. Notice that when you do a limbal vitrectomy, notice that upward drag, the whole vitreous body tends to jump up anteriorly, something that's not visible with the naked eye on a routine microscopic or a surgery. But if you slow it down, you realize how much it's moving. And a small PCR that you saw is now has a sharp edge. It's expanding like a zipper. Compare it to a pars plana, in which the irrigation is through the limbal route through a side port, and the vitrector is in the pars plana, and notice that there is no movement of the PCR margins, and it's so simply controlled that you can clean up vitreous completely. Not only in the area of PCR. So again, this is a myopia apple view where we are recording, you're operating from the top but recording the eye from the bottom. Notice that if you do a limbal vitrectomy, you have a very, very small area to play around simply because you're limited by the anatomy that you're approaching. You can only clear your vitreous in the area of the PCR. Compare it to a pars plana, you can move all around. You can not only move in the area of PCR, but go beyond that to clear up the entire area of the vitreous base, a little bit of the anterior vitreous face, so that the IOL has a symmetrical scaffold. Now, what would you want to do? You want to do a small little just to save grace, or you want to clear up the bed completely and have a stable centered fixated IOL? I'm just going to run you through a case because that is the final litmus test. So this is a patient, second eye, undergoing a restore, multifocal surgery. Everything goes as per plan. The IOL goes into the capsular bag. Tend to place the IOL right in its place. It's a well-centered IOL, and then I'll go ahead and this is the end of the surgery if you look at it. And everybody is done and dusted. Finally, go ahead and do a bimanual irrigation aspiration. It's very important to keep the aspiration out of the posterior capsule open area, and that's exactly what I'm doing. But for some reason, the posterior capsule was weak, and there happens a big PCR over there. The IOL is in the bag, and what would one do? I understand there is a PCR, you're committed to looking for vitreous. A good way to look for vitreous, like Nishant brought about, is to use preservative-free triamcinolone acetate after securing the incisions and making sure there's no prolapse happening. I'm trying to reposition the lens, hoping that there is no vitreous, but nothing happens, so I stain the vitreous. And like Nishant said, there is vitreous right at the incision because that is normally where it would prolapse. Now, the big question that arises is, how do you approach this? I approach it the pars plana way. So I'm making a trocar entry, but if you don't have a trocar, don't get scared. Use an MVR knife and just make an entry and suture it later. There's nothing great in suturing. But notice that with the limbal irrigation and a vitrector posteriorly, this entire vitreous body that had come anteriorly drains back right through the PCR into the posterior compartment. And it is so visually appealing to see the whole thing going back to where it belonged and you clearing it up right then and there. And you started a limbal route, this would keep on draining, and then you would have to go through one side port, another side port, and it will go on, and the PCR would enlarge, and you'll have to explant the lens more often than not. Once you've severed the connection between the vitreous that is prolapsed anteriorly and the vitreous that is drained back into the vitreous, whatever little is left behind in the anterior compartment can then be tackled limbally, because there's nothing wrong with doing the limbal vitrectomy for taking off that guillotine little bit vitreous that is left behind. And then you finally, again, going beyond the areas of the PCR and going across, like I showed in a myopia apple view, you can clear up far more than you aim for with a limbal vitrectomy. But what's the final result? Finally, you are able to center the lens. The PCR, which happened here, got limited to its presence over there and did not enlarge, extend at all. This is the patient at 3 months follow-up with the multifocal lens in the eye, second eye which you committed, well-centered, stable IOL, 360 degrees capsular excess cover. Good side is the PCO patient might not develop a PCO in half the lens anyways. So the choice is ours at the end of the day to see a well-fixated lens that we've managed to go through just because we chose to go through a pars plana route, and that one incision that we are scared of can always be tackled with one suture. Needless to say, the patient needs to be referred to a retinal surgeon, but the choice at the end of the day left to the audience. Would you want a lens like this in the sulcus just because you are scared of doing a pars plana vitrectomy? Or would you rather go ahead and spend that extra half an hour with whatever machine you have, with whatever cut rate you have? And if you don't have an MVR setup, you just a trocar, make just an MVR, make an entry, do a pars plana vitrectomy, have a well-centered, stable IOL. Thank you.
Yeah, over to you, Dr. Nishant. Your chance.
Yes, I just have one small.
I can't hear you. Just.
Hello. Am I audible?
Yes.
Yeah.
Yeah, I just have one small, second, sir, for retaliation. Yeah, so as he said, I wanted his financial interest of high-speed cutter and the Miyake machine, which shows in a place when you place the lens, and then I agree with Samresh that is the best way. But when you come into the PCR, first is irrigation aspiration, then is phaco, and last is coming IOL placement. I just have one person who will definitely agree with me, who will fight for me. I just want all of you to see the video which was presented in IIRSI, one of the leading international conference. Just please, all of you listen to wide ears. That one person who will support me.
In the vitreous, it's a good idea to stain with triamcinolone. My choice of vitrectomy is generally the limbal vitrectomy here, because in certain situations with the limbal vitrectomy and bevel turned upside down, you can get enough clearing in that area. Yeah, I think Nishant, you caught me there, because sometimes you got to defend the other things as well.
I think Nishant is a very dangerous man. He's like a Tehelka tape he's showing there here. Wonderful, Dr. Nishant. Dr. Samresh, you would like to counter telling it as a forfeiting or the capped video or something like that, or would like to counter your point?
No, I think that I was trying to make a point over there that if you're scared of pars plana, you can still do limbal in a small PCR which has a rounded edge, but he didn't show that part.
Fantastic. Great. So because he comes from the land of pilots, so he knows how to handle situations very well. Thank you, Samresh. Thank you, Nishant. That was a wonderful debate.
Thank you, sir.
So being a vitreoretinal surgeon, I'm always biased because of the pars plana route. So let's hear from a more neutral man today. We have a senior most respected Dr. Debashish, sir. Your thoughts on these, please.
Yeah, I think both of them made wonderful points. Obviously, Nishant's presentation was fantastic. Never hit from the back, and Samresh, as usual, coming from the school of teachers, tried to put the perspective right. I think anterior vitrectomy is something which we have grown up with, but it's time that we really consider the pars plana vitrectomy because of so many advantages which Samresh mentioned. And he just mentioned that obviously the vitreous won't come up and the rent won't enlarge. But think of other situations where you have the two halves of the nucleus still there in the eye, and then there is a vitreous. You have a lot of cortex behind, and still you have to, you have a PCR at that point. So, I mean, in those situations, we need to, Nishant showed the American Academy poll, but then, there was that 20%, and this is the beginning. I think we have to mature, and this part, I think we need to learn. So I think I'll pick Samresh as my teacher.
Thank you, sir.
But Nishant, very well done.
Thank you, sir.
Thank you so much, sir. Thank you.
Request Dr. Chitra, madam. Over to you, please.
Thank you very much, and the youngsters had really did well. So we shall now go on to another vibrant issue for debate. With so many proficient cataract surgeons, don't you wonder why you need to get an examer? So we have with us a young, dynamic Dr. Gitansha, who is going to tell us exactly with every literature backup as to why she thinks what she does. Phakic IOLs for all refractive errors against phakic IOLs for extremes of refractive error. But then we also need to know that we have Dr. Krishna Prasad, the unbeatable, the unchallenged hero from Hooghly, who's going to be a deadly opponent, who is going to have his own sound reasons for his cause. So let's hear from you, Gitansha. Your lead first.
Thank you. Good evening to all of you. So over the next few minutes, I'm going to describe as to why phakic intraocular lenses are my solution for all refractive errors. I have no financial disclosure. Now, there are a couple of characteristics of the phakic intraocular lens which make it my procedure of choice. The lens is biologically inert. It has a better optical quality, a larger optic zone, and higher efficacy and stability as compared to the kertorefractive procedures. Now, what makes this lens inert? We all know that the cholamer has a high affinity for the fibronectin in the aqueous, which forms a layer on the lens and subsequently protects it from the inflammatory mediators in the aqueous. You can see that an acrylic lens, which is routinely used in cataract surgery, has a dense protein deposition within a minute of exposure, as against the near absence of proteins on the surface of the cholamer. Now, one of the disadvantages of placing an implant in the eye might be that the internal reflectance would result in secondary images and result in photic phenomena such as glare and halos. However, the internal reflectance of the cholamer is the same as the crystalline lens, and it does not result in excessive amount of glare and halos postoperatively, which is not the case in ablations following keratorefractive procedures. The quality of vision as against the MTF, the Stills ratio, and the OSI have shown that the quality of eyes undergoing this phakic IOL implant is the same as that of a normal eye. The higher order aberrations again are significantly lower as compared to other implants, including silicone, Acrysoft, and the Sensar lenses. Now, one of the most important advantages would be an enlargement of the optic zone on the cornea. The effective optic zone is 1.25 times the optic zone of the lens, which means that while we're treating powers of up to 13.5, we can give the patient an optic zone of 7 millimeters or greater, which is not at all possible with any corneal-based procedure. Now, my opponent may say that the complications including cataract are one of the potential drawbacks. However, with the advent of the central hole models, the 360-degree micron hole allows a good movement of the aqueous, and the rates of complications such as cataract have drastically reduced. They also allow a lower vault, and studies have successfully shown the implantation of phakic IOLs in AC depths as low as 2.4 millimeters over a 4-year follow-up. Now, Cochrane reviews have also shown that the phakic IOL vis-a-vis the excimer laser has a greater efficacy, a better safety, and a better contrast for both moderate as well as high myopia. Again, a number of studies have shown that even in low myopia, the performance is equivalent to the high myopia, and the higher order aberration profile is definitely significantly better than laser vision correction. Now, one can argue that these lenses are more costly to the patient. However, the Indian varieties cost the same as the femtosecond laser as well as the SMILE procedures. Additionally, there is nil initial investment for the surgeon, wherein one does not need to spend money on the femtosecond or the excimer platform, and no additional surgical training is required, and any surgeon who is comfortable with cataract and the anterior segment can do this procedure with great ease. Special situations like corneal ectasias, both idiopathic and iatrogenic, patients who've undergone an intracorneal ring segment implantation, or patients with a lamellar keratoplasty can also undergo these phakic implants to correct their refractive errors, while this obviously is a contraindication for keratorefractive procedures. Again, one of the important things that one of the other important things is that once the patient develops a cataract, the IOL power calculation is essential. No special formula is needed with the phakic implants, thus one can get more accurate results post-operatively. So I just like to conclude that there are obviously a large amount of advantages of the phakic IOL over the laser vision correction, which makes it my procedure of choice for even the low refractive errors. Thank you.
Very good talk, Dr. Gitansha. Dr. Krishna Prasad, she has raised many valid issues. We really need to fight for your cause.
Thank you very much, ARC, AIOS, and Dr. Chitra and the team. So, phakic IOL should be reserved only for extreme refractive errors. I think the other one thing, I mean, the opposite of this has been told by my opponent. I think to speak, I mean, opposite to this particular topic of mine, it requires a great deal of brave heart and good measure of clinical ineptitude. I mean, let me probably introduce Dr. Gitansha for you. Dr. Gitansha, young people are basically very impulsive, like Dr. Gitansha, a lot of cortisol and a lot of adrenaline, because they're very impressionable. They believe the company narratives very easily, and they are vulnerable to market pressures. And whatever the people say, they are not very resilient. They quickly change, and also they lack the wisdom theory. So corneal procedures for low to moderate myopia, refractive errors, and phakic IOLs for high myopia, this has been a common understanding and a common sense. Okay, I think what is the beast, the beauty and the beast? The beauty here is the LASIK and the SMILE, which we have been doing for a long time. And the beast is the phakic IOL, which has its own share of problems. See, the LASIK and SMILE has been the best thing that has happened in this century. the newer technology that have come in and the new very skillful surgeons bringing a lot of innovative techniques, okay, we have the better understanding of corneal biomechanics, and the pathophysiology of ectasia has been very well understood, and it has been time tested, and it's also economical because ICLs are very costly for the patient, especially the toric vitrectomy, the phakic IOLs, much easier with trans-P arcade surface ablations. So this is a very important question that I want to answer. Why anybody wants to perform a phakic IOL for low to moderate myopia? Now, when Dr. Chitra asked me to take up this topic, I said, Dr. Chitra, there is no debate here. My opponent will be in great trouble. That person will be defenseless. Please do not give this. So this will be very difficult for my opponent. But she said that is exactly the point, because I'm giving to Geetansha, who is my daughter-in-law. Okay, so the borderline corneal thickness, she said for borderline corneal thickness, probably there is a case for ICL. But we know that with the present day techniques, the kind of new innovation that have happened in the corneal refractive surgery, we are able to take care of this. She said this photopsia. I think if you have a hole right in the center, you may create, solve many problems, but that itself can cause this photopsia. Reduced contrast, and they say there's a lot of aberration that are induced. Okay, the fear of ectasia, the problems with IOL power calculation. See, you have cataracts with ICLs and phakic IOLs. So there the problem of IOL power estimation comes. For refractive surgery, if you are doing to low to moderate myopia, you don't have to worry about cataract and even the IOL power calculation. So let me tell you, this phakic IOL is a demon if untamed. There's an intraocular procedure. In an young patient, you are trying to put something into the eye. There's a possibility of endophthalmitis. Inflammation, you are trying to put a foreign body between a clear, well-functioning crystalline lens and an iris, which is extremely sensitive. So you're going to create a low-grade inflammation in that patient forever. And I'm a glaucoma surgeon myself. I've seen so many problems where the angle has been compromised by a wrong sizing and intractable glaucomas leading to removal of ICLs. But obviously, cataract formation tops the list because over a period of time, the vaulting changes and invariably it leads to lens touch and cataract formation. There are a lot of unresolved problems. Sizing has always been an issue. Whatever is the technique, whatever is the place, everybody has a problem with white to white, sulcus to sulcus. It can never be, it has not been resolved so far. And also we know that there's a gradual reduction in the vault, almost every 15 microns per year at least. Finally ends up with reducing the wall to almost dangerous. Toric phakic IOLs rotate postoperatively. It's not like a capsule sticking to a toric IOL, but the toric phakic IOLs do rotate postoperatively. So there are three, whatever villains you have, you want Mogambo, you want Joker, you want, whoever, cataract formation, endothelial cell loss. In a young patient, you are putting it in foreign body there, and there is 0.6% is a gradual loss every year, but we have something up to 7% endothelial cell loss per year. It can be really scary. And once you do an intraocular procedure, you're going to change the vitreous dynamics. There's an increased risk of OD in these patients. See, low to moderate myopia, don't worry, Geetansha. We have femtolasic where we can do thin flaps. We have smile extra and residual stromal thickness. It need not be a bugbear. We have a lot of, we do understand ectasia is caused by so many other factors. And it is still a treatable cause. So please save our patients from a myopic, the wrong slant, the wrong photograph. This is the photograph from myopic surgeons. No, we do have to have. See, very literature savvy. She pulled out so many literature telling extolling the virtues of ICL or in low to moderate myopias. But eminence-based medicine says that whatever has been time tested, well proved, that we need to. So we need to exercise caution in our judgment. We have to stay extraocular. We know cornea well by now. So let us do a corneal procedure. Let us not create a traffic jam within the anterior segment leading to glaucoma and inflammation and unwarranted posterior segment problems. And let us perform an advanced corneal laser procedure, which are available so that we can have a well-established and very rewarding results. And very importantly, let the good sense prevail. So this is something I would like to say. Let us not create new problems just because that we know. ICL for extreme myopia, I do agree. But for low to moderate myopias, we have well-established procedure of laser vision correction. Let us stick to the rule book and let us have happy patients. Thank you very much.
Good, Dr. Krishna Prasad. Geetansha, you have a minute to rebut me. Don't spare him.
So thank you, sir. I just retort to your points one by one. The first thing you said was that the procedure is not as economical, but like I've already pointed out, that the Indian varieties cost the same as the procedures such as femtolasic and SMILE. Again, you said that there is an increase in the, now we know much more about the corneal biomechanics, because of which we can carry on laser vision correction safely. But we also know that patients who have early FFKC or any form of ectasia cannot undergo these procedures, and we have to resort to phakic IOLs. Again, yes, being an intraocular procedure, there might be a slight risk of inflammation, but like I've already shown, collagen is exceedingly inert and the risk of inflammation is negligible. Yes, there could be a risk of infection, but even LASIK comes with its own set of unique complications. Sizing and rotation is not an issue as long as proper preoperative measurements are taken. You also pointed out that there is an increased risk of retinal detachment, but that is more in patients in which PVD has not used or they have a high myopia. But in cases of low myopia, the risk of retinal detachment is exceedingly low. And I just like to end by saying, as regards wisdom teeth, I have all 4 of them.
Okay. Quickly, I'll probably say you are very literature savvy. I do appreciate that, Gitansha. Very well done. So, ICL is really good. I do understand that. You have all the literatures to say that ICL is extremely good. But why do it in low to moderate myopia? When we have very good results with our SMILEs, our PRKs, patients are very happy, we're staying extraocular. Why go inside the eye and create a new problem for a young patient? Cornea is a much more well-known territory, and basically a myope, even a low or moderate myope, when you go inside, you're going to change the dynamics to an extent. So we have seen patients with ICLs coming with great problems. So let us not create a new problem in a patient, especially low to moderate, which can be very well corrected by so-called the present-day laser vision corrections on the cornea. That is exactly my point. Thank you very much.
Both spoke very eloquently, and so was the rebuttal. But I now want the president of AIOS, not Gitansha's father, to leave the right take-home message to all of us.
So I think the take-home message is that the mother-in-law.
I'm your student also, sir.
Yeah,
I'm your student.
I'm not giving anything to you. I'm saying that the message to take home is that the mother-in-law throws the daughter-in-law to the wolves. But because you are my student, so therefore you did justice and things.
I got my compliment, sir.
Yeah. Good. So in any case, I think there are lots and lots of people who are going in for the ICL procedure as regards the procedure of choice, especially those who don't want to miss out on being refractive surgeons, vis-a-vis not being able to afford an excimer laser or a femto. But I think obviously the topic that was given to Gitansha was to a large extent against what you said was the commonly agreed principles of tackling low myopia, since it's a time-tested gold standard kind of a situation. And I know that Gitansha also does the same. So obviously she's being asked to bat with both her hands tied at the back. But I think there are lots and lots of people who are actually wanting to do this procedure as a procedure of choice. The number of people doing the ICL and especially the Indian equivalent has increased. And there are a lot of surgeons in the periphery who do not afford these laser vision correction. They are doing it. But I think even if I have to do it for low myopia with extremely good corneals and rest everything, no dry eye, etc. I don't know whether she pointed out, but I think dry eye is one of the things where you would wish to prefer to not touch the cornea. So overall, yes, I would tend to agree with the general practice of low myopias being done by the excimer laser or the femtolasic or the SMILE. That's about it.
Yes,
Dr. Chitra, I want to say something for a moment. Can I say something?
Gitansha did a great job and very eloquently, and I'm sure made us all think. And rather, I have been wondering often enough that the Phakic IOS results are so good. There could be many more cataract surgeons who don't have excimer who could go ahead and do it.
Dr. Chitra, can I butt in for 10 seconds?
Chitra, I would fully agree with you. And forgive my ignorance, I think, we're doing this for the last 10, 15 years, Phakic IOLs, and the results have been so consistent. And the more we do it, I think it becomes the refractive procedures as such become more popular, and especially hyperopias and other things which don't yield, and even, correcting presbyopia now that we have the trifocals stabilizing. So all in all, I think Phakic IOLs as a refractive procedure, forgetting our excimas and our smileys, I think can be a good thing for.
Dr. Gaurav, your thoughts?
I wanted to say that Dr. Mahipal has been very unfair to Gitansha. She did such a great job of, defending her case. And I fully agree that now the future is with low powered ICLs. I've been talking about it as well. And she did a fantastic job of, defending this difficult topic, but she was up to it and better.
I think it was a one-sided kind of this thing, and there was no debate in it, but Gitansha just fought back very nicely.
Thank you. Thank you.
Dr. Krishnan Prasad, you did very well too. So we go on to our next team, Dr. Srinivas.
So on to our, so after hearing from the perplexing debate from the two vociferous speakers, so let's move on to our next strong team. We have Dr. Vaishali Vasavada, a very versatile surgeon and a strong speaker from Jaipur, is up against Dr. Naren Shetty, the Prince Charm of Narayan Netralaya, with the great skills in the set of the complex surgeries. So let's hear from both of us. So Dr. Vaishali will be talking on how to address the lower grades of astigmatism in cataract surgery with toric in all cases. And Naren would be speaking that LRI and the arcuates are for the lower grades. So over to Dr. Vaishali, please. You're muted.
I'm so sorry. Thank you, sir, and wish you many happy returns of the day. Madam, Dr. Chitra, many, many thanks for making me part of this so interesting debate session. And I'll try to keep up to the spirit. Can you see my screen here now?
No, not yet.
Wait, we're just sharing. Open it.
Okay, sorry for the delay. So I think as I have been very well introduced, thank you for the kind introduction. Of course, we all have a financial interest in managing astigmatism. That's why we are all here, and same with me. And I'll start my debate with saying that believe what you may want to, but only that works what you can prove. And I'm here to prove the science of my concept and offer proof of this concept that low astigmatism is an entity that should only be treated with toric IOLs, and I don't think it's even a matter of debate. So good luck, Dr. Naren, with all due respect. Does it matter? Does low astigmatism matter? Would be the question many surgeons would ask. Well, we did this study many, many years back, and in eyes with a monofocal IOL in the bag with a best corrected vision of 6.6, if you took eyes that had between 0.5 and 1 diopter of refractive astigmatism, they still ended up with poorer contrast sensitivity and a lower reading speed, even if you gave them glasses for correcting that 0.5 or 0.75 diopters of astigmatism. So the fact is that anything that is beyond 0.5, that means 0.5, 0.75 matters, leave alone 1 and beyond, which was traditionally talked about when this whole astigmatism management started. And again, as has been discussed throughout all the debates, literature talks about it as well. And a recent study shows that 65% of cataract-going patients will have anywhere between 0.25 to 1.25 diopters of corneal astigmatism. So why not treat it? Of course you need to treat it. And many of us forget that you may measure only 0.25 or 0.5 or 0.75 in the cornea, but you're going to add at least 0.2 or 0.3 to it with your surgery, if not more. And therefore, at least 55 to 60% of our cataract surgery patients belong here. And I really liked what Dr. Himanshu said, that we are all here to give the best outcomes. Yes, we want to make money, but our primary aim is to offer them the best outcome. So why a toric IOL and not an incision? I think the out and out pro points for any toric lens. I'm not talking about a particular brand. And now we have very good Indian lenses, which are so much more affordable. They are components of routine surgery. They're accurate, they're predictable, there is no regression, they can be reversed. We all know about all this. And this is just from today morning. I just typed toric intraocular lens on the PubMed, and you have 960 articles giving testimony to the fact that it is a technology that has worked and continues to work more and more. There were two great meta-analyses, one from the Cochrane, which compared toric IOLs and LRIs for corneal astigmatism. And it does say that astigmatism correction-wise, toric IOLs do much better. There is no debate. Another review from China, so that's why I put the Cochrane review first, even if you don't want to believe this. It also says the same thing, that toric is better than incisional surgeries. And then there was one in 2015, way back, which said that when you treat low degrees of astigmatism, the toric lenses do equally well. It's not like they're not effective. In fact, they were more effective and more predictable compared to incisional surgeries for correction of low astigmatism. And I know that with the advent of femtosecond lasers, because big setups have invested in them, you have to get something out of it. We are talking more and more about AKs, but they are incisions. Incisions are incisions, and they have their problems. This is real data from our clinic that 65 to 75% of our toric IOLs are designed to correct up to 1 diopters at the corneal plane. That means low astigmatism. So it's good for your practice, it's good for your patients. And the fact that 70% patients are taking up this technology, leave aside the cost alone, means that it is working. It's not like we are pushing it down their throats. And if we were not talking about refractive surgery of presbyopia correction. What would you do if you have an even 0.5 or 0.6 diopters of astigmatism? You just can't put in any of your read-offs or multifocals or whatever kind of presbyopia correcting IOL. So you need a toric version. So I think I really don't need to even start talking about the problems of incisional surgery, like scale and surface symptoms, regression, what is the effect, what nomogram do you use, how much do you charge for the diamond knife or your femto AK? Of course, it's not going to be free of cost. So I think it's a lot about hesitation, and we as doctors need to step up where cost alone should not be a deciding factor and manage our own hesitation. And I would just like to end by saying good luck, Naren. Thank you.
Thank you, Dr. Vishali. Thank you very much. Over to Dr. Naren. Go ahead, please.
Thank you, Dr. Srinivas. And thank you, Chitra ma'am and ARC and AIOC for giving this opportunity, and great presentation, Dr. Vaishali. So today I was told to talk about or defend, let me press this button. Okay, to defend LRIs and AKs in low-grade astigmatism correction of cataract surgery. Or in a way, I'm supposed to talk against toric for all patients of low astigmatism in cataract surgery. As you can see, there's a very significant number of low grade of astigmatism in pre-op patients. But since we are living in India, majority, or let's say 20% of are below poverty, and 17% are in the lower caste category. So are we justified to push all these patients for toric IOL? I really don't think so. Is there an alternative with no extra cost? This is where the LRIs and AKs come into picture. Now, why is it advantageous? There is absolutely no extra cost for the doctor and the patient, so they don't feel the pinch. Secondly, once we do it, we we give them much better vision for distance, and they don't require the glasses for distance, and also they can get rid of bifocal glasses. And in fact, if you do the monovision in the other eye, in fact, the patient won't even require near glasses. I don't have the data for India, but the spectacle lifetime expenditure in the US for an average person is $2,100 to $3,400. And in Europe is about $1,700 to $4,600. Now, the next thing is, believe me, the patient satisfaction is absolutely amazing in these patients when you do the LRIs and AKs, because the expectations is very low and they are absolutely free. They're not paid any cost. But it's not so in patients who choose toric IOL, because their already expectations high and they feel like it's their birthright because they paid something. They feel like they should get 100% get rid of the astigmatism. So to satisfy these patients, if something goes wrong, is very, very difficult. Now, the next thing is, please, I want to tell the point that we are doing this free of cost. So it's almost like we are doing a service to the community. And when we do this, the gratitude these patients have for you is completely, unmeasurable than any other patients, or if you do a toric patient who really can afford for it. So the next thing is, even if you look at middle class patients, and if they do take out from their savings and go for a flak surgery, again, asking them to shell out, money for a toric IOL when they have low grade of astigmatism, I feel, pretty guilty for it. You can always suggest it, but you cannot force it, definitely. So now let's look at the different error points. Now, when we look at error things, means the points where things can go wrong. Now, when we look at the LRIs and AKs, there's always a chance of incorrect scans, calculation errors, marking errors, depth of incisions, and also there's a chance of regression. But when we look at the toric IOL, we have multiple factors. So we have inadequate K readings, incorrect calculations, improper patient selection. Then there's always a chance of inadequate pre-surgical marking, defective capsular access, misalignment of IOL cylinder, and also post-surgery, there's a chance of rotation because of retained viscoelastics, and the ratio between the capsular bag and IOL is not good. Then there's a chance of rotation, or it can happen because of hypertonia or overinflation of the bag. So if you just look at pure factors, there is lesser factors in LAs, LR and AKs as compared to the toric IOLs. But this, I want to stress the fact that this doesn't mean any of the procedure is more superior. I'm just trying to say is there are many, many factors which you have to take into counter. This is one of the reasons why there is a high variability in toric IOL surgeries. When you look at unilateral, there's about 60 to 85%, which a lot of studies suggest that. And also when you look at bilateral, it ranges from 69 to 70. 69 to 97. So I would like to conclude by saying, is it right to push all lower grade of astigmatism cataract surgeries for toric IOL? I would really disagree. I would believe if the patient is affordable, if the astigmatism is 0.75 or more, then you can always go for a toric IOL. But if the patient is not affordable, which will be in majority of our cases, please do not push or ask them to shell out more money. Always go for a free LRI, AKs or OCCI or even CCIs. This way you're doing a free service to your community, and the blessing that you will get of free service is completely unmeasurable. So at the end, I want to say that the best way to find yourself is to lose yourself in the service of others. Thank you for your time.
Thank you, Naren. Vishali, I think now it's your time after the philosophical little bit of ideas given by Naren. Now I think it's a time for your refutation.
Thank you, Naren. Thank you so much. I have been a fan, and I'm listening more and more to a certain very learned doctor whom you happen to know, Dr. Bhujang Shetty. And I listen to him. I think he tends to say that be stress-free, enjoy what you do and give your best when you're doing it. It's only one life. So I think I will do my best. And I also thank you for bringing out that point about the bifocal lenses. They're really so expensive, even more so progressive. So why not do a toric and give your patients only a 250 rupee ready reader again? And like I said, you said it's a free service, good, but it's not a service every time because one, most people will not do it free. And when you're doing flax, I don't think if you ask 5 or 10,000 more for an incisional surgery, it becomes more of a theoretical debate. But I have seen almost every patient of mine whom I do an incisional procedure is unhappy, at least in the first 3 to 6 months. And they would rather say that I would have maybe borrowed or asked my insurance, my agent would have fought a little more with the company. But maybe I wish I had gone for the toric lens. So I rest my case.
Thank you, Vishali. Naren, I'm sure that you still stand strong on your ground. So
yeah. Thank you, Dr. Vaishali. I think the point is, see, for doing LRIs and this, I don't think so. Charging extra, money for that particular incisions, doesn't make sense, because if you buy one of these blades, then you can keep reusing and reusing. I think it should be okay that even if you do it free of charge, especially people who can't afford, and give that better vision for them, and the happiness that they get out of that is simply amazing. Yeah.
great. Thank you. And I think, dear viewers, this debate is going on and on, the more fierceful fight. Now we have the Chief Justice coming in. I think, Madam, now I leave it to the fine sense of your judgment.
So,
Dr. Namrata, Madam.
I understood, Srinivas. I think it is always all about economics, and this debate has also fallen into the same trap of economics. One person trying to defend against the other. The whole thing, in fact, has been low economics versus high economics. And again, like I said earlier, it is also about the patient affordability, what he can afford. But having said this, the threshold for astigmatism, for implanting toric IOLs in cases of astigmatism, is decreasing. Earlier it was 1.25 diopters, then 1 diopters. And I think one also has to take into consideration whether it is against the rule astigmatism or with the rule astigmatism, because obviously if it is against the rule astigmatism, then your thresholds become even lower and you can go as low as 0.75 diopters. But again, having said this, there is also an issue of quality of vision. With toric IOLs, the vision tends to be better as compared to with LRIs or OCCIs. But again, it is also about affordability of the patient. So I think it is a balance between the economics and also between what the patient wants ultimately and not what the surgeon wants. So the surgeon can convince in any manner, but if the patient is not being able to afford it, you can't do a toric IOL. And I'm sure if the patient can afford it, even Naren wouldn't want to do a OCCI in that case.
True, ma'am.
So you would still want to do a toric. So I think one has to balance between, what you have to counsel the patient and what the patient wants. Eventually, he may again have Googled and found that, he wants the best IOL to correct his cylinder, which is correctable by the lens itself. So very well, both of you did a great job, and it is difficult to, say who did better, but very well presented, both of you.
Thank you, ma'am. Thank you.
Dr. Namrata, for being with us.
Thank you.
Thank you, Chitra.
Plus, you can go on with the next team.
Yeah, go ahead, Madam. So now we'll move on to our next set of speakers. So we all know that the next hot topic is the controversy on addressing the myopic progression in school children with atropine. And for that, we have Dr. Arun Samprati, a very capable pediatric surgeon from Bangalore, who is also the chairman scientific committee of the prestigious Bangalore Ophthalmic Society, against our very dynamic ARC member from North, who got elected unopposed, is Dr. Rohit Saxena, the professor of pediatric ophthalmology from RPC and a member of North Zone, to accept the challenge raised by Dr. Arun. Over to Dr. Arun, sir.
Thank you, Dr. Srinivas, for the wonderful introduction. First of all, I would like to thank Dr. Srinivas and Dr. Chitra Madam for giving me this opportunity to present this atropine for myopia control. First of all, my screen is visible?
Yes, sir. Yes. You can go ahead with the slideshow.
Yeah. So first of all, I would like to tell, like, whenever you do a refraction for a child and tell the mother that the power has increased, the first thing is that she will tell, why did the power increase? In spite of wearing glasses, the power is increasing. Is there nothing in the world to stop this one? As if you are at fault. You are the cause for this increase in the power. That is what the attitude of the mothers will be. So all these days I had to just cut a sorry figure and say nothing. I don't have anything to offer. And unfortunately now we have the Ramband. That's the atropine eye drops, which can control the myopia. So if you see the pandemic, before the corona pandemic, myopia pandemic was there for a long time. From 5% incidence of myopia in the world, it has almost gone to 22.9, and the high myopia is about 2.7% of them. And by 2050, it is expected to go to 49.2%, and 9.8% of them will be high myopia. So Dr. Rohit will ask, what is a big deal? We all know that myopia is just not myopia, it's associated with so many degenerative retinal diseases, glaucoma, cataracts, besides the cost and this thing of the optical correction. So though we cannot stop the onset of myopia itself, we can definitely reduce the progression so that we prevent it going for the high myopia. So what are the current available modalities? There are a lot of things like the progressive glasses, contact lenses, environmental modifications, but the only thing which has been conclusively proven is the pharmacological modification. So to date, the atropine has been the only medicine which has been demonstrated to consistently be effective in slowing myopia. Initially 0.5 and 1% were used, but they were having a lot of problems with the poor near vision, and they are not able to tolerate it. And also there is an incidence of rebound myopia. Hence, the recent studies have shown that 0.01% of atropine is extremely effective in retarding the progression of myopia. It is associated with minimal side effects, and 98% of the children, they tolerate it very well, except a very few children who may have near vision problems. And also the rebound myopia is less in this concentration. So the atropine does not work through the accommodative system. It works through the specific M1, M4 receptors on the retina. And also it has a non-muscarinic effect on the scleral fibroblasts. Is there any scientific proof for this? Yes, there are a lot of articles. The most important is the ATOM study. The ATOM 1 study studied 1% atropine. However, this was found to be problematic because it causes near vision problems. And then the ATOM 2 study was done where they compared 0.5, 1 and 0.01%. And they found that 0.01% is extremely effective in controlling the progression of myopia. So what are the ocular side effects? You may see very minimal. Very rarely you see photophobia, slight blurred vision, and a local allergic response. So all these effects are very minimal, and most of the children tolerate it very well. So in conclusion, atropine is the only ray of hope in reducing the rate of progression and controlling this myopia pandemic. And it has very few side effects and very well tolerated. It can be coupled with environmental modifications such as increased outdoor activities. And I would like to conclude by saying my opponent has already conceded the defeat when he is quoted in a public paper from the Kerala Journal of Ophthalmology, where in an interview he has stated that I have been using atropine eye drops for control of myopia. Thank you.
Thank you, Arun sir, for your intellectual thoughts. Over to Dr. Rohit. Yeah, you are muted, sir.
Yeah, is my screen visible?
Yes.
Okay, thank you. Thank you, Arun, for quoting me, but you have not quoted many other things which I will be quoting, which I have been talking about. Sorry. I'll just full screen it. So my worry is not about pharmacological projection, but the aggressive pharmacological projection that is going on to prevent myopic progression in children. And I don't have any financial interests. And unfortunately, there is a lot of financial interest in this massive projection of atropine, and I'll discuss. What do we know about this? And as Arun brought out, that it's like the corona pandemic. Childhood myopia is like the corona pandemic. We do not know much about the disease. There is huge fear mongering. We are clutching at straws for treatment, and we do not know how this treatment we are touting actually works. We'll take each point separately. While parental worry for myopia is there for more than 100 years, increasing near work has been blamed. Our mechanism or our understanding why it's happening is unclear. We've talked about lack of play. Academic high achievers have it. Tabs, phones, computers are at fault, although they are a very recent addition to our children. Television, vitamin D deficiency, nowhere, no one has ever shown atropine deficiency as a cause. Huge fear mongering. This article is oft quoted, just quoted by Dr. Arun. The big thing, although I respect this article and it's a wonderful one projecting 50% myopia by 2050, this report actually missed 1/6 of the world's population, that is India. Our prevalence at the moment is around 10%. 3 of our papers have actually shown this. It's important, need to worry, but not crippling, not that fear mongering we are talking that make us ignore facts about the treatment we're talking about. We're clutching at straws. This is not a revolutionary or a miracle discovery done for treatment of myopia. Atropine for myopia dates back to the 1960s. Doses have been tested from 1% to 0.01%. Despite having more than 20 years of experience in low-dose atropine, it's still not FDA approved, believe it or not. It's not marketed anywhere in the world, including East Asia, where 70 to 80% children have myopia. It's not even licensed for sale in Singapore, where these ATOM studies were done. It's only for SNEC enrolled patients, except in India, of course. It's an over-the-counter drug. You can take bath in it. And of course, probably we'll soon have atropine eyeliners and mascaras as a treatment option. Talked about ATOM 1, Dr. Arun did. 1% versus placebo showed that it's effective, but too many side effects. It acts probably by accommodation arrest. ATOM 2 tried to reduce that by 0.5 and 0.1. And 0.01 was the placebo. It was 100th the concentration of 1% that was effective and considered a placebo. They found that it's effective, but atropine is dose dependent and so are its side effects. So 0.01% is acceptable, not scientific evidence. In fact, right on cue, we now have a low dose concentration available, which is 0.05%, which is showing it's more effective than 0.01 and has equal side effects or very less. And there is this huge puzzling disconnect. 0.01% atropine slows refractive changes, but does not slow abnormal eye enlargement. Any myopia control must slow the rate of eye elongation because that is the cause of side effects in pathology's later life. At present, this just reduces the power of glasses, no long-term safety. In fact, this recent viewpoint has very aptly put that despite evidence that it is not showing eye elongation reduction, it is being rapidly adapted in clinical practice and widely used, which is both unfortunate and concerning. It is completely harmless, as Dr. Arun said. We just don't know how it works. It acts through some receptors, but then what are those receptors for which we are blocking? There are no side effects today. But remember, we need to put these drugs at least for 2 years in growing, developing eyes. 2 years daily
60 seconds left.
12-year-old children. 1 year just to see efficacy, plus the rebound effect. So rapid myopia occurs the moment you stop, atropine drops. Is this the best available treatment? My biggest objection is that it diverts attention from alternate and proven effective treatment. Outdoor activity, multiple studies have shown more than 2 hours of outdoor activity definitely and significantly reduces progression. Soft multifocal contact lenses are now FDA approved for control of myopia. Orthokeratology, other drugs like pyrinzapine, 7-methylxanthine, timolol, all have shown effect. These are the alternatives, and this graph of atropine that you're seeing is all the doses that you have, and you have a lot of alternatives. And so I leave you with this photograph of keep myopia away, go outdoors and play is the slogan from Singapore, where atropine came out, and it's not go use atropine. Please show your aggressive behavior in educating the patient, giving all the options, encouraging outdoor activity, which is actually free treatment and good for the general health. And don't bind the child ears with treatment that is yet to prove itself. Thank you very much.
Wow. Great, Rohit sir, for sharing your lightning and fast moral points. So, Arun sir, you want to make any comments to save yourself, please?
Yes, I've already told that he has considered effect. So when he said that 2 years of treatment is necessary, the ATOM 2 study is a 5-year study. So they had 2 years of atropine followed by 1 year of washout period. And if there is a progression, they used to use it for another 2 years. So it's a 5-year study and they've already done this study. And regarding the environmental factors, I also emphasize that environmental factors are important. It should be a multi-pronged approach. It's not that atropine is the only treatment for myopia. So it should be a multi-pronged approach, but atropine definitely offers a ray of hope for these children. Otherwise, we used to see like what I have quoted the figures, 9.5% of those patients are going to become high myopes. And Dr. Srinivas Joshi will have a lot of work because he will have a lot of retinal detachments coming to him. Thank you.
Thank you, sir. Yeah, you're combating points, Rohit boss.
So I'll just reiterate, the key problem is elongation of the eye, which as of now, 0.01 has not proven to show that it arrests elongation of the eye. It may arrest the refractive error moderately, but the key problem is the myopic retinopathy and retinal changes and the risk of RD, which it will not affect if it does not limit the elongation. So at the moment, it is a drug that is under study, and we still need a lot many questions answered before we start giving this drug to the growing eyes of our children, because we don't know what's going to happen 10, 20 years down the line when we block these receptors when the eyes are growing. So I think a lot of caution is necessary, and it's a misplaced aggression, probably driven by a lot of hype and pharmacological push by a lot of companies that are marketing it.
Thank you, Dr. And I think both of the opponents rest their case. And now we will leave it to the judge. Actually, both the opponents need not be really scared, because he's one of the most diplomatic and ever-smiling personality of the judge we have is none other than Dr. Gaurav Luthra. And I'm sure he will do justice.
But Srinivas, this time I'm caught because both people have spoken so well. I'm in a quandary. They both make their points so well, and frankly, I have been following this debate not just now but over the last few years on to see what the final verdict is going to be. Yet I feel that I think both made their point really well, and that finally is the answer to this debate. I think first of all what Rohit said about spending time with each child and each patient, counseling the parents, the child, and each time on their visit, counseling about outdoor time. All those things are so important, and I personally believe in that as well. Yet, so I think lifestyle modification, advice, everything, counseling, all that is probably the first line of action which we should all be doing. Atropine should not be the first line of action anyway. Yet there will be that small subgroup of patients where in spite of everything, you notice that things are not going the way that you want. Parents are really concerned. They're trying their best. They're educated. They've been trying to kind of do everything that they can do right, and yet you notice. And then we have done put some of those kids on atropine, and yes, we have seen a couple of patients over the last 2-3 years who have probably I don't know whether it's placebo effect or whatever it is. It does seem to work in those handful of patients where we've tried it. So I definitely will. And then Rohit also mentioned about the few other areas which we could work on. I'm sure that there are lots of ways to work on, and atropine is just one of them. In India, I don't think the pharma pressure is that big because atropine, thankfully, in India is really cheap. Yet, I think we should keep our minds open to all the things which are possible. And I think that's about sums it up. That yes, we should not close the door on atropine either. And in some cases where it does work, and I think a lot of new studies are going to tell us more about this way or that. So I think AIMS should lead the way and conduct a full study on this with a huge group of children. That would really answer this question even better in the long term.
Thank you, Gaurav sir. As I said, definitely he did justice to both of you all, and also to the panelists and the audience. Thank you very much. So I think it's the time for the last debate, and I should congratulate Dr. Chitra madam and whole ARC team. As of I have attended most of these AIOS webinars, I think this is the most time-going webinar. Just 10 minutes left, and all the delegates are still watching. Very interestingly, very intuitive talks are going on. Over to Dr. Chitra madam, please.
Great talk, Dr. Rohit and Dr. Arun. There was always a learning in these debates too. The last team to meet head-on is an equally important topic of concern, more so in this Corona times, PG education program. We have with us a very endearing and popular teacher from Allahabad, Dr. Kamalji, to acknowledge that the present-day PG program is adequate, as against our ever-dynamic Dr. Meenakshi Swaminathan, who headed the postgraduate education at Shankar Nethralaya, and I know she has led it to great heights. And she would pose strong points on why she wants to revamp the system. So we have a thing or two to learn in this debate. So let's hear what Dr. Kamaljeet has to say. On to you, Doctor.
Thank you. Thank you, Dr. Chitra, and happy birthday, Srinivas.
Thank you.
It's really great to be amongst the topmost speakers in the world. And it has been on time, so I was waiting since long, but it's well on time. So I'm so much impressed by the panelist and the chairman of this debate.
And also thanks to Sunil also for keeping up the time.
Yeah, Sunil has done a wonderful job. Yes, that's all. Regular presentation is going on. There is no interruption.
Don't lose out on your time, Dr. Kamaljeet. Get to your
Yeah. So the training program is governed by postgraduate regulation of the 2000 year, and what is our goal? The goal is to produce competent established specialists who are expected to master most of the competencies. And if you look at the techniques of training, you will find that it remains the same. It does not change since long. And when a student comes to us to do MS ophthalmology, he has already done his MBBS, and perhaps I think that he has wasted 6 years of his youth in learning the art which he has to unlearn later. When they join, they know nothing about ophthalmology. There is not much of teaching in ophthalmology in MBBS. The whole course lies in the interest of the medicine and the surgery and gynetics. So the process of unlearning begins from the day they join the post-graduation. So first we make them specialists, and then they have to be made super specialists. So they learn what they have learned in MBBS, and then they unlearn what they have learned in MS ophthalmology and become super specialists. Methods remain the same. Mostly we have to ask our students to go to OPD wards and do refraction, seminars, general discussion. Only problem that I feel is the research and didactic lectures. The teachers in the department, they don't take lectures usually. It is the other way around, that the residents teach the teachers. So didactic lectures are very important. That is not there. And statistics is missing because we don't teach much of statistics. They have to do research work, and many a time they fail in that. So I went through several literature, and I found that what is the goal of this? You have to train them, surgical training, academic training, and you have to make them a good teacher also. So these goals have to be achieved. And further, I went through the literature and I found several very good articles on this PG education. And I found that the shortcoming that is there is that they don't assist in the posterior segment procedures, corneal surgeries, laser surgeries. That is not available in most of the medical colleges, and therefore they lack in these specialties. So this calls for a serious introspection by the authority to allow such institutes to keep the training at a par, so that they learn a lot in various subjects of the ophthalmology. So there are fellowships after that. You learn cataract, refractive surgery, glaucoma, retina, and pediatric ophthalmology and oculoplastic. So that also comes up. And in the year 2006, when I gave my presidential address, I said that it's cataractology, and cataractology, and it still holds true. The training program has not changed at all. And what about the trainers? They are not trained. What I learned about 30 years back, if I am interested, I go to various conferences and then learn. And otherwise, I have lack of knowledge. And there is so much of exposure of new gadgets is required that many a times trainers fail. So there is explosion of new information, which is very, very essential for the teachers to learn, and there is no program for trainers. So my submission here is that this debate is not for just the opposition. It is for the constructive suggestions.
60 seconds.
And okay, not just for the sake of opposing, and we have to reach to some solution, and it should not be futile debate like we have in parliament. So basic problem is infrastructure that has to be developed, and whether the instruments are functional or not. All these surgeries can be learned if you have a good infrastructure, which is not available there. Syllabus remains the same. Whatever you want to teach, you can teach. Only these even these basic equipments are not there in many of the medical colleges. So the infrastructure is more important than anything. Journals are very few in the library, although you get these online these days. And students are more interested in learning the surgery rather than publishing things. And publication is just for the promotions of the consultants. Wet lab facilities are very poor. Mode of need of the hour is a structured review of the training program, and it should be always regulated, peer reviewed. And there are modules available in ICO and NBE also, so you can always look at that and finish off that. My proposal is that you have to teach them how to do a good spectral business, contact lenses, financial support should be there, a good clinical setup. And you look at the MBAs, they work for 2 years only, and they think of making an industry, and what we think of is opening a small shop close to the barber shop. So that all that should be changed. And I would say that Dr. Meenakshi would agree with me, and we can come to some conclusion later. Thank you.
Thank you, Dr. Kamaljeet. Dr. Meenakshi, we look forward to your recent thoughts. I think Dr. Kamaljeet has made it a debate, a rather one-sided win for you. Dr. Meenakshi?
Yes, I'm right here. Can you see my slides?
Yes.
Okay. A very happy birthday, Srinivas. And Chitra, thank you so much for this kind invitation. And wonderful program. I've enjoyed all the debates so far. So much to learn, how to debate, how to elegantly debate. Very proud to have so many Shankar Nethralaya alumni as part of the program. Okay. And Dr. Kamaljeet has already said that my topic is the valid one. So really, I'm not going to spend too much time, but just for fun, since it is the last debate, I just thought it'll make it a bit fun. So all stories in this presentation are the result of only my imagination. I give Dr. Chitra complete credit for this self-discovery of my hidden talent. Any resemblance to real life situation is scary as hell. Oh, worthy opponent, I offer my argument. So somewhere in an Indian PG residency program, second year PG, good morning, ma'am. I want to discuss our curriculum with you, ma'am. Next 3 months, I'm posted in glaucoma, ma'am. Ma'am, curriculum? Curriculum? Who put this idea in your head? That SR? I am your thesis guide and internals also for the exam. What early morning creating complications? PG, oh, sorry, ma'am. I just wanted to know what I should cover. Sorry, 1 second. Ma'am, I don't know. Go, block the next case. 2 years later, she has finished MS, but she's called Dr. Missed It. Patient comes into the clinic. She says, a patient says, good evening. I went to 2 doctors and they found 2 different powers. So I wanted to get it checked by you, doctor. And then Dr. Missed It says, my technician is on leave. I can do by computer method. Hey, turn that switch on and dust that machine, no? And then patient says, doctor, but you yourself cannot check. And then doctor says, you know what, technician will come, you come back next week. And in another part of our great country, this is Dr. DNB, do not bother. Patient, good morning. Today I took leave and brought my child. She has squint and maybe vision is also less. She is only 3 years old. Dr. DNB is now scratching the head. How to check this brat? You do one thing, no hurry. You come when she can read all that ABC and all. Patient says, but you know what? I Googled it and they said that I should not delay. DNB, okay. We'll put some drops and we'll do something. Last scenario, I promise. This is Dr. D.O. Don't know. Patient comes and says, I just got transferred to the bank here. I was told before I came that I will need laser treatment to prevent some pressure attack. And Dr. D.O. says, sir, that is very advanced treatment. I will have to send you to the main branch. Patient, but sir, that is 300 kilometers away. Now, I am not joking. Where is the evidence for this kind of scenario happening? This is the READ study. This was published in the IJO in 2017. It stands for Residency Evaluation and Adherence Design Study. Basically, they polled young ophthalmologists, postgraduates who were finishing their residency program and asked them, hey, how was your clinical training? How was the teaching? How was the surgical training? These are the results. And you will be scared to see what the results are. Just a second. Here is a list of all the procedures that they are supposed to know. And if you look, refraction, on a confidence rate scale of 0 to 10, 5. As you come down, look down, 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 down. Pediatric visual acuity testing, 2. Retinal lasers, 1. Gag iridotomy, 3. And somewhere where gonioscopy also is a poor 6. Now, why are we fussing about this? Is it really that important? It is important because what is the prevalence of diabetes in our country? 77 million. That is the number we are looking at. What is the prevalence of angle closure glaucoma? Various studies have said various things, but it can be even up to 4.3%. Our PG does not know how to do gonioscopy, does not know how to do laser iridotomy. What about refractive errors? 6.1%. No, PG doesn't know how to do refraction. What about visual impairment in children? Most important cause is refractive error. PG doesn't know how to examine children. So, Santosh wrote very nicely in his editorial. Ophthalmology residency training in India, Covardis. Should we look at the American style? ACGME accreditation guidelines. Oh, we don't have time for that kind of detailed documents. Okay, so maybe should we look at the ICO residency curriculum? You know, it says international, but really I was part of the ICO residency curriculum. It's really very Western in nature. So really, what do we need? What do we need is an India-centric curriculum. And Dr. Grover very eloquently in his article outlines it in 2018. And this was followed up by this publication on national curriculum for ophthalmology residency training. I was even wondering, is this an important topic? And I found on PubMed that Indian postgraduate residency curriculum, in the last 5 years, there are 20 publications. You don't talk about this unless it's important. So do we need to change? Without a doubt. It's about time. Otherwise, you'll get doctors from University of Google and University of YouTube who will be treating us in the future. Thank you so much, Dr. Chitra.
Thank you very much. That was a very informative talk by both of you. But is there any need for a rebuttal? It seems both of you are on the same thought process that we need to revamp the whole process. I wish as leaders
and in fact, I think I was going to say you, Dr. Chitra, and the leaders of the AIOS, you have to be the events of change. You have to be the bringers of change. You have to be the angels of change who need to bring change to our ailing postgraduate system. No better than you people. That's my appeal. I think Dr. Kamaljeet agrees with me. That's our combined appeal to you. Thank you so much for bringing this to light.
Thank you very much. Dr. Kamaljeet, any thoughts?
AIOS should talk to the government of India and MCI and see that the infrastructure is available, and because all the postgraduates are equally intelligent and they can do all the jobs that they do after their MS to learn and they do in their fellowship. So if this infrastructure is there, all of us can learn all the things. And I know that the stalwarts sitting here, they have not done any fellowship. My pal had gone for cornea. My pal had gone for cornea, and but he's doing all refractive surgeries, all IOLs, except for he does everything. Gaurav has not done any fellowship, and they're doing all the best that is feasible. And they have learned during the course in the later years. So it's not essential that we have to go in for fellowship. Only thing is infrastructure is lacking, which should be improved. Thank you.
Thank you very much. Dr. Devashish, your final words on this?
Yeah, I think this is a very serious area and we really need to look at it. I think the other thing, as Professor Kamaljeet said, infrastructure in our government medical colleges and private medical colleges, I find that the patients are very inadequate. I mean, they, infrastructurally, they may be a little more up to date. But having said that, you know, the entire environment, when one thing goes wrong, a lot of things follow it. So essentially, I think what the PGs lack nowadays is they are not, the interest in ophthalmology is not created, which is our lacunae, which we have to create their interest in ophthalmology. And of course, they need to learn, but they need to create that interest in ophthalmology. And unless the infrastructure is there, then it really doesn't happen. I mean, from the first day, they probably start thinking that, you know, I will learn cataract surgery, and by doing as many cataracts as I can, because wet lab facilities are not available, so they don't put the rigor that is required to go through the wet labs before they really expose themselves operating on a human eye. They, you know, all complement or, you know, discomplement each other. So yes, I think AIOS, everybody of us should take this part very seriously, because the future is losing very critical time, as Dr. Meenakshi pointed out. I think the fellowship is, as also Kamaljeet said, that Professor Kamaljeet is making the point very right, that, you know, why should somebody require a fellowship? Of course, you know, if he's doing something ahead, but for a basic ophthalmic practice, I think an MS should be competent enough to go and start practicing. So all this said, I think we should really focus, and all of us, so that, you know, the content of these students and their interest in ophthalmology, the ethics, these things should be put very right.
Debashish, unfortunate, this is Himanshu. I totally agree with this. Is a very important debate. It's not a debate, actually, it's a monologue. Unfortunately, the postgraduates are at a loss. They are not even done 5 cataract, and there's so much of sadism existing in the whole system. I think there's a lot of rot existing, and that needs to be looked at very strongly. Fellowship is like, it is your postgraduate 3 year is a waste of life most often than not. It's very unfortunate, and prime years of life of most of these students is at stake. So it's very important, more than the rest of the whole debate that we have had. This is the most important point conveyed in this.
True.
Himanshu, I'll just want to make a point. Actually, you can't paint all the postgraduate curriculums with the same brush. There is a lot of diversity. That is what we need to attack. It is not that what I learned in post-graduation in All India Institute of Medical Sciences, and Dr. Kamaljeet, doing a senior residency is like doing a fellowship, actually. And what I did in senior residency, whatever I am today, I would say that I would owe it totally to what I learned, the skill set that I learned in All India Institute of Medical Sciences.
That's the teachers.
The only thing that is problematic is that there is a significant thrust from the government to increase the number of seats. That is the only thing that they are wanting to show it on paper, that the number of seats have gone up. Say when we were doing MBBS, maybe 10,000 seats, now 75,000 or 80,000 a year or whatever. So the number of seats have been increased without caring for the standards to be maintained. So there is a dilution of standards. There is also a dilution of the lack of faculty who is teaching in the colleges there. So unfortunately, what you said, sadism, I would say, yes, there is a problem. It is not sadistic. I would say it's an insecurity. Whenever a person does not want to teach is when a person is insecure himself or herself. So normally we have heard stories, which is true, that the slit lamp binoculars were kept in the almaras by the people when we were this thing, and you wouldn't even allow a resident to have a look from the slit lamp, or you are not allowed to use one particular microscope, or you are not allowed to. There is a sense of insecurity because they don't. I would be most happy if my student becomes better than me, because then I have achieved what I wanted to achieve, that the student has become better than what the teacher is. Unfortunately, it is the mindset of people not having enough and trying to be very protective of what they have as teachers and not opening it up to the others. That is the unfortunate, the lack of facilities of people, of institutions not having equipment, of institutions not having great teachers. That is the main problem. That is the bugbear. And I remember Dr. Kamaljeet came to us in All India Institute when there was a program called Train the Trainers. So where ECC IOL was trained in this thing. So I think those kind of things have to be done. And whatever AIOS can do, the problem is the infrastructure. Even despite the COVID, I don't think the government is going to significantly change the amount of GDP that is going to be spent on health. Until, of course, there is a thrust of GDP spending on healthcare. You see any government institution, they would not have any equipment. And if they have equipment or technology, it is out of order for reasons which could be it could be malicious, or it could be motivated by somebody, whatever it is. So the
finances also.
Yeah, I know both. Either it is not there, or it is there, it is not working. So that is the problem. So it is a very, very big problem where, until of course healthcare is given primacy, your quality of people who will be coming out would be very poor. So that is a big challenge that we have. And I think, as you rightly said, it's a monologue. Actually, we are all together in it, and it's one voice that we have to say that the postgraduate teaching and training has to be improved. And that's one thing I also say against SICS, that people are trained for SICS in big institutions and they are not taught FACO deliberately. It is that they have to come back for fellowship and then.
Please don't say deliberately, Dr. Maipal.
Okay,
we at RIO, we have 3 machines and there are 150 surgeries going on. So the workload is so much.
Kamalji, that is not a problem. The machines are easily available. What I'm just trying to say is, okay, I may not use a strong word like that. So the point is that we have to have openness as regards what we are teaching to our fellows or to our postgraduates. That's all. The thing has to have a significant overhaul. There has to be a uniformity in the curriculum and OSCE, etc., whatever you are doing across the board. Like DNB has across the board the same exam. It's much difficult to pass a DNB exam than it is to pass a MD, MS exam in peripheral college. So I think a lot of work has to be done, and I think we are all together in it, and we should try to push the betterment of the postgraduates and the teaching and the learning abilities that they have.
Just one point I would like to make here, that one professor today is allowed 3 candidates for, he has to see the thesis of 3 students. 3 students in 1 year means that for 3 years he has 9 residents with him. So it has become so difficult, as you have rightly said, that the MCI is just increasing the number of seats, not bothering as to how the training would go.
Absolutely.
I have just a last point. Rohit. Maipal sir.
Yes.
A different thought I wanted to put in, a bit of introspection. What I wanted to just say was that I agree all these things are big issues, but when I was doing MBBS, we had a lot of MBBS doctors practicing as GPs. Today, MBBS is what BSc was in my time. You're a graduate, but you cannot get a job. You're not employable. This is what is happening to our postgraduates. They are postgraduates, but nobody is going to give them, because we are projecting specialty so strongly that the postgraduate has started thinking that I may become a postgraduate, but I cannot practice ophthalmology. I just don't know anything. I need to be a complete senior residency in RP center or a fellowship in one of the places. Without that label, the patient will not come to me. Doctors will say that, who's this guy? Yeah, this guy doesn't know refractive surgery. He's doing cataract, so he doesn't know refractive. He doesn't know cataract. He's not a specialist. How are you going to him? That's the huge mental pressure our postgraduates are under, and that's why they're
What do you say of refractive surgery? They cannot even do a good fellowship. Person who has done fellowship in retina cannot do a good refraction. So many a times in myopia, they keep on searching for OCT and angiographies and OCT angiographies. So that too is the other way around. If you look at that, that is also.
Yeah, I'm just saying the flip side, the other side also, that we've made everything so super specialized that there is a constant pressure to get better and better, train better. So that's, again, you make a better postgraduate, give him the confidence that he can practice and do a good job. Great.
Just a few words. I mean, we have always, I think the message that comes across is that we are going for quantity and quality is being compromised. We've been talking about it for many years. Ashok Grover was very passionate about it. I think if it comes to it, it's AIOS which has to make a difference. I mean, I think we have the wherewithal, the power, the respect that needs to be done. And it's most important, as was pointed out, there's a wide variation between the quality of postgraduate program that's offered. And some of them come out well equipped, some of them are very poorly equipped. Even after a fellowship, they're not good enough to handle anything. If only we can get some kind of a curriculum, some kind of a process there in place, which is followed all across, not only at the postgraduate level, but also at the fellowship level. We did have a program with the ICO. There's an entire curriculum that's available for every fellowship program that needs to be conducted across the country. I'm not sure that anybody is aware of it at all. To my mind, maybe this segment is the most important segment of the entire proceedings of the evening. And if something comes out of this usefully, I think that would be a great step forward. I think it's up to you, Maipal, to take this forward with the help of Mr.
All of,
Consider.
yes, all of us.
Yeah.
All of us.
I think I just want to make one point, Maipal sir and Kamaljeet sir, Meenakshi madam, when you said, so in Karnataka, last year back, we started something called as Karnataka Ophthalmic Teachers Academy. I think KP had turned that coin. So what we did here is, see, a lot of things, differences are going on between the DNB as well as the MS medical colleges. Some of them say in DNB you learn more practical but not theory, and in MS they say you learn more theory and not more practical. So what we thought was to bridge the differences. And in fact, it was so spectacular that all the teachers took it so positively. And we got a call from the Rajiv Gandhi University, which is one of the biggest universities of healthcare in India, especially in Karnataka, that do you want any changes in the curriculum in the post-graduation? I think these are the things, if we can make the certain changes, as Meenakshi madam said, I think that will benefit both MS as well as DNB's education to a large extent.
No, I'll call you in 10-15.
Ma'am, can I make a small suggestion if it's okay?
Yeah, go ahead.
Yeah, actually, I mean, just a small suggestion that, see, if at all we are trying to say, okay, we have to accomplish a surgeon completely well equipped after postgraduate, I would say is, like, I feel over the years, the first 2 years, they have to find the student what is his interest, so that in the final year they can give a little more emphasis on that. So because what happens is in a college, it becomes a little more difficult to give everyone a chance in everything. Sometimes it becomes challenging, especially in the final year. So if they can, in the first 2 years, if they can, see how the student is doing, how better he's doing, if his interest is more in cataract or more in refractive, more in retina, in the final year, maybe they can give him a little more cases on that, maybe, tweak his skills a little bit in the final year. And I believe, you see, how we have theoretical assessment of how good the student is, I feel practically, surgically also, we need to have some kind of an assessment. So the surgeon, once he the student, when he finishes the surgery, there's some kind of a grading of how his skills is at the end of the PG, so that it's more clear that whether he requires a fellowship after that or not. So with the grading itself, even the private institutes will be happy to look at the grade and say, okay, he's a very good skills. From PG itself, we can take him up. So
I think as far as the PG mindset is concerned, it's extremely important to make sure they understand that ophthalmology is not cataract surgery. I have kids, my own kids doing postgraduate residency. They only count it by the number of SICs that they have done. So obviously there is a whole life ahead of them to learn cataract surgery. It's extremely important that they drive home the message that they have a comprehensive exposure to ophthalmology as a whole, and it's not equated just with the number of cataract surgeries that they do.
That is why in my arguments, Dr. Ramurthy, I did not talk about surgery at all. We have to talk about basic skills like gonioscopy. We have to talk about refraction, which most people really cannot do anymore. We don't have that many good optometrists to support us either, or pediatric vision examination. These are all very important skills that many programs do not impart.
Yes, Dr. K.
Sir, we have been talking about the problem. I think just like I want to add to Srinivas talking about the solution. In Karnataka, as he told, we have what is called KOTA, Karnataka Ophthalmology Teachers Academy, which is basically a loosely bound organization where every organization, every teaching institute is loosely bound, and it is basically a self-governed thing. The idea here is, see, why we have enough resources among the institutions, enough opportunities for all our students to learn things. Like Shankar Netralaya has a lot of facilities we don't have. So we probably collaborate. So it's basically in a state, the institution don't come together for a common cause because of either self-interest or disinterest or maybe egos or maybe technical issues. if we can bridge all the institutions with a single cause of patient, I mean PG welfare as a common cause, I think we have a lot of strengths to share. Our weaknesses can be taken care. I think what Kota in Karnataka probably is just, I mean, it's going on very well. So I think this can probably be an example which can be emulated in other places where each institution, as you said, some institutions have some strengths and others have some strengths. So we can probably come together and take care of our weaknesses. I think this can be one way of looking at it.
In fact, the university was perplexed that they started asking us that, do you want any changes in the curriculum? And I think these kind of approaches, if we change and make it at the state level, I think it would be really a good rationale to update the PG curriculum.
We also wanted to have a primer course. For all the students who join that year in that state, the institutions will chip in their resource persons. We will have a 5-day primer course for people who join ophthalmology, so that they will get all the basic training in the priming of before they start the PG, something like that. So all these things are possible probably if we come together.
Dr. Chitra, can I say 1 minute and then can I also have my say? Yeah, I think everybody's understood. I mean, everybody is on the same line, but I just wanted to add 2 things. One is that the concept of senior residency, as Dr. Maipal said, was very good. Rather than fellowship, a senior residency gives a chance to, work in the area that you would like to work. For example, you might get posted in retina if you like retina, or so once you've done a PG, you get much wider exposure. So you come out as a comprehensive ophthalmologist at the end of PG. AIOS can play a big role in setting up the curriculums and bridging that gap. Second thing I wanted to say was that a few years back, ARC used to have accredited AIOS accredited fellowship or something similar kind of a program where, participating institutions without monetary benefits really would be accredited for imparting small post MS fellowship programs where they were qualified or, they were like kind of recognized for doing that. We could revive something like that. So to fill in the gaps of what is missing from the PG teaching programs in some places, because every place will not be able to come up to that level as we aspire, even if AIOS steps in and the MCI steps in. We could kind of do this kind of a small 6 months or a 1 year thing where people could post MS, they could be facilitated to go to a small accredited program without being expensive or anything. And then ARC could play a big role there. So I thought I'd chip in with that.
Already in the pipeline.
Very valuable suggestion, Gaurav. We need to come to an end to this webinar, but there have been a lot of things which were discussed here. I think the first step would be like each of us who have a postgraduate training program in our own places should go back and do some kind of a self-retrospection and see how best we could improve. And that may be those smaller steps which would take us to larger steps. And as an ARC, we should see what we could do a small bit towards this very major problem which exists. It has been a fantastic 2 hours. I'm sure it's not something which I felt alone. Each of the speakers gave so much of energy and just to the whole program, and there was so much of scientific content, and it was nothing very superficial either. So thank you very much, dear speakers, for putting your life and soul into giving the best talk. Each of you did the best. And of course, a very energetic expert panel who definitely ironed out the final take-home messages. Thanks to one and all of you for the impressive fight you took on. A very special thanks to Mr. Nikhil from Mentor and his entire team for sponsoring all our ARC webinars. A special thanks to AIOS Kripal, his team, and of course, Mr. Sunil for the seamless webinar they have ensured. A special thanks to Numerotech and Sai for being the support system for ARC, and my very own, very dear ARC team for their strength and backing, which they have given me at every single turn and every single event. Hip hip hooray. A special thanks finally to our dear attendees who have been loyal and consistent and have been a major source of encouragement for us. Hope you all enjoyed it, and I hope we do meet you again in some of our webinars ahead. Thank you very much. Look forward to seeing you all in many more of our ARC programs of future. Thank you, one and all of you. Thank you.
Thank you to you too.
Thank you.
Thank you for the opportunity, madam.
Thank you.
Thank you,
Thank you, madam, for the opportunity.
Thank you, ma'am. Thank you.
Thank you. Good night, ma'am. Good night, everyone.
Good night. Good night. Thank you.
Bye-bye.
Bye.
Happy birthday, Srinivas sir.
Bye.
Thank you.
Thank you.